So good afternoon, everyone. Thank you for joining. It's lovely that all of you could join for the first session of BIC 2020. I would like to introduce everyone who's present here. I would first want to start by welcoming Dr. Rustam Dotov. He's a chief intervention cardiologist specialized in CHIP from Brisbane. We also have Dr. Balbir Singh, who is Chairman Max Healthcare. In the panelist, we have Dr. B.B. Channa, who's Chief Intervention Cardiologist at Maharaja Agrasen Hospital in New Delhi. Dr. Sanjeev Roy, Director Cath Lab Fortis Hospital, Jaipur. Dr. B.V. Manjunath, HOD Department of Cardiology, AJ Hospital and Research Center. Dr. Prabhat Kumar, HOD and Vice President of Medical Hospital, Patna. Dr. Omar Hassan, Director Intervention Cardiology, Allahabad Heart Center. Thank you all for joining, and we will start with the first presentation by Dr. Rohit Mathur, Associate Professor from MDM Hospital. So if you could share your screen.
Yeah, good afternoon, everybody, the panelist, moderator, and chairperson. Hope I am audible and visible clearly.
Yes, you are, sir. Yes, you are.
Am I audible? Right. Thank you very much. So it's always a pleasure to be among interventional cardiologists from all over the globe. And what better utilization of time than sharing the knowledge. So here I am, Dr. Rohit Mathur. I am Associate Professor of Cardiology in Government Medical College, Jodhpur in India. And today I will be talking about some modification of existing techniques of left main bifurcation, which I used in a particular case. So this was a 65-year-old female who presented to one of my colleagues with non-ST elevation MI. She was a non-diabetic, hypertensive female with adequate blood pressure control. Her ECG revealed T-wave inversions in chest lead, and her resting echocardiogram had no left ventricular wall motion abnormality, with the ejection fraction being close to 60%. So after initial stabilization, she was taken up for coronary angiogram by my colleague. She had a left dominant circulation with a significant lesion in proximal LAD. The rest of the vessels were pretty much won't say normal, but didn't had any significant obstructive lesion. So after discussion with the family and the patient, she was taken up for angioplasty to her LAD lesion. So you can see that there is a proximal LAD lesion, and my colleague started angioplasty to this LAD lesion. After around 40 minutes of starting the procedure, I had a call from Cath Lab that the patient has collapsed and there is a lot of thrombus in her LAD. When I reached, I found that there is a wire in LAD, and obviously there is a lot of thrombus in ostial LAD lesion. With my colleague trying to balloon that out, he has given GP2B3A inhibitor. The flow in LAD is really poor, not more than TIMI1, and in circ there is TIMI2 flow. By the time I got scrubbed and got into the cath lab, because of some ballooning, GP2B3A and everything, the flow in LAD has marginally improved, as well in LCX. Patient is still having chest pain. Her STs are showing significant deviation on monitor. Pressure, which initially was 50-60, now with some flow and inotrope support, came to say 80 or 90 millimeter of mercury. So when I reviewed the slide, you just want to bring your attention to the time. This was 12:10 p.m. When I reviewed the slide, what I found was that my colleague has dissected the left main, and this dissection, which was done at 11:15 only, has gone unnoticed. They kept on doing angioplasty, missing the ostial LAD, left main dissection. So now is the case of a dominant left circulation, left main being dissected with a significant, false lumen we can see. There's a lot of thrombus in ostial LAD and some in ostial circ as well. So there are some issues. First and foremost is hemodynamic instability. You have a left dominant circulation, flow in LAD is TIMI1, and everybody would admit that we need to deal with LAD first. The other question is that would you take a single stent from left main to LAD, keeping circ stenting as provisional, or would you take a 2-stent strategy to start with? So we were of the opinion that it's a left dominant circulation. There is some thrombus in LCX ostia as well. We were not comfortable leaving LCX territory, and we thought that it's better we take 2-stent strategy to start with. When you decided that we are going for 2-stent strategy, the biggest problem was that my colleague was working with a 6 French guide catheter. And there was hardly any time to escalate because the patient has crashed. There's hardly TIMI1 flow in LAD. When you talk of doing a bifurcation stenting with 6 French guiding catheter, you are left with either a tap strategy or a step crush strategy. If you saw the initial videos, the angle between LAD and LCX, that is distal main vessel and side branch, was close to 90 degrees, which suited tap technique. Circ was more angulated, and of course this was the side branch. Now the second issue was size disparity. The size of LAD, that is distal main vessel, was 2.75 or at the best 3 mm. The size of proximal main, that is left main, was over 4. And LCX was at least 3.5. If you put a finite formula as well, 3 LAD and 3.5 LCX, you would expect LM to be at least 4.3, 4.5. So you can do a tap strategy where you can put in a stent from LM to LAD and keep LCX as a side branch, but then you would need to take a LAD stent of 3 mm and do a pot up to 4.5 maybe. Theoretically, you can do it. Bench testing has shown that most of the good quality stents can, 3 mm diameter stent can go up to 4.5, but practically we are not comfortable when you take the stent to over more than 1 mm diameter of its nominal range. So what we decided was some innovative thing. What we did was we wired LCX, and then we took a 3.0 into 23 everolimus eluting stent and positioned it right at the ostia of LAD, into the LAD, covering the original lesion. That is, we stented the only distal main vessel arm, and after stenting, it showed good result. We post-dilated LAD, the flow improved, and then we took another 3.5 into 28 mm everolimus eluting stent, positioned it through LM to LCX and stented. Now you can see that there was TIMI3 flow. Rewiring of LAD was very easy because this was a straight segment. This was not angled. Rewiring of LAD was done. Post-dilatation of LAD with 3.0 and LCX with 3.5, with final kissing of 3.0 in LAD and 3.5 in LCX, with a pot of LM stent with 4.0 stent balloon was done. We actually did not require 4.5. And when I did this angioplasty, unfortunately, I didn't had imaging with me, but final angiographic appearance was very good. The patient was in my follow-up till last year, she was doing all good. I can show you diagrammatically what exactly this is, though the diagrams are hand drawn and may not be of good quality, but this is how my case was. And a classical case of T or TAP stenting would be, there would be a proximal main vessel, which was left main in my case, a distal main vessel, which was LED in my case, and a side branch, which was LCX. So when you do a TAP technique, which is most of the time provisional stent technique, when you stent the main vessel, that is LM to LED, and if you find that the side branch vessel has compromised, you can keep a stent into the side branch with minimal protrusion and inflate it. In that case, you don't need to rewire, and this is what classical TAP is. At times, people do reverse TAP, where you put in a stent in side branch with minimal, protrusion inside the main vessel, and do main vessel stenting later. This is what reverse TAP is. But here what we did, because the proximal main vessel and side branch were of approx same caliber, you can put in a stent from proximal main vessel to side vessel, and then probably you do a distal main vessel, which is inverted TAP. In my case, because the distal main vessel, that is LED, was more critically, got involved, and there was slow flow, and there was a need to do that vessel first. What we did was that we only did distal main vessel first, and then we did proximal main vessel to side branch stenting. When I searched for the literature, I found only one, a case which was presented in TSC, and this was an oral abstract which was published in JACC, where the operator had done proximal LED to diagonal stenting, and then they did TAP to LED distal to this diagonal, and similar was done. And so in my case, modified inverted TAP, the results were good. And there are some take-home messages. Left main bifurcation stenting, it does require technical expertise, but it requires dynamic thinking as well, particularly if an emergency. You need to think fast. You need at times to think innovative. There are no set rules, as we call coronary to be pseudo effective. So in my case, because we were playing with 6 French guide, there was a discrepancy in proximal and distal main vessel size. Proximal main vessel size being closer to side branch size. There was a 90-degree angle, and need to stent the distal main vessel, that is LED first. It led to invention of this new strategy. And this new strategy of modified inverted TAP is effective, it's simple, it's fast, and it provided adequate coverage of both side branch and main vessel ostia. Thank you.
Thank you for your. It was a little. I think we have 10 minutes for every case, and so without much can I call on Dr. Balbir? So for his expert comments, plus then he can move on to his key lecture, the True Master's View. Dr. Balbir, of course, everybody knows, is the chairman, Max Healthcare.
Thanks, Nikhil, and Rohit, a great case that you showed. But this case is very debatable, and there can be a lot of questions on this case. My biggest problem against this technique is that in this case, LED truly was not involved. The ostium of the LED was not truly involved. If you are doing this technique, either you will miss the ostium, or you will be a little more in the left main that you will have to crush that stent. You can't be perfect in this technique. So you're lucky that the ostium was not clearly involved in the first angiogram. There may have been a dissection which was in the left main. So this technique suffers that neither it's a crush, nor and you have a chance, every chance of missing the ostium. You can never be perfect that you covered the ostium. And that's the problem with this technique. So that's why it's not so.
Well, with this kind of 90-degree angulation, I think that the best case is to do a IVUS. If you can do imaging, that's the best thing. At times, before I had IVUS with me, we have been doing all these kind of cases with angiographic eye only, and that I know is shortcoming. but we had been doing all, and if you see this angiogram again, you'll find that the Oscar was good covered. I do agree that IVOS would be a better choice.
Just
Dr. Mathur, it's a great case. What I suggest sometimes can be done, and I do this when EBU or XB is sitting deep into the left main, touching the carina, just put a wire in the circumflex, just to make sure that the guy doesn't keep hitting that with injections. And in this case, I would still try to do provisional, as you said. Majority of stents will go to 4.5 from 3.0.
Yeah.
With a good pot, and then decide if I need to do tap.
Here I would like to add one more thing, that I agree. I admit that my initial assessment of left main size could have been wrong, because we know that once there is dissection, because of this dissection flap, the lumen appears more, bigger. So probably what I think was that the left main would be more than or close to 4.5. Maybe it was not 4.5. I would have taken a single stent from left main to LAD and do a pot, and you can come out. But I think my assessment of left main size might be erroneous because of that dissection flap.
Okay, I think when we move on to Dr. Balbir's key lecture, master's view from the master.
So I'm going to show a case and bring down the point that the biggest enemy of an interventionist is nothing but calcium. This is a diabetic 56 years old lady. This is her angiogram, and you see the calcium. The circumflex is not so severe. The LED in the see the pointer, you can see in the mid part and the proximal part there was an LED. Now you see there's
I think there's a glitch in the network. We lost Dr. Balbir. I can't see Dr. Balbir anymore.
Sir, we lost him due to the internet connectivity issue.
So till he comes back,
He is connected.
Yeah.
I think we could. Yeah, he's connected.
Okay.
So I'm sharing the screen again. So let's look at this right coronary artery. So this was the left and this is the right. So if you look at this right, so there were these here, then but not so bad. Place 1 or 2 spots, and we now thought that so the biggest enemy for us is the calcium. So what strategies could have been used to tackle this calcium? One, we could have used the rotablator. This bend was too much, which was little worrying to me, this 90-degree bend for the rota. Second option was to use a scoring balloon. Third option was to use a cutting balloon. Again, this bend and too much calcium made me think that I will be able to create only a perforation. Fourth was to use a shockwave balloon. My worry was whether I'll be able to cross this lesion with a shockwave. So keeping all this in mind, we thought, let's go for a rota. So we took a 1.5 millimeter burr and were able to burr this lesion, the entire lesion, with almost 3 or 4 passes. And there was no drop in RPM, and it looked quite good. We were very uncomfortable in crossing the distal lesion. The proximal lesion didn't take time and was easily burred. So I thought now the things will become very simple, as it normally does become after a rota ablation. But it wasn't, so I wasn't that lucky. We were able to cross with a balloon. Both the lesions were dilated. We used an NC balloon, but then I couldn't cross the stent. We took a 3 into 18 millimeter of the best stent that could pass. We took but couldn't cross. Now here I've used a guide liner, and I want to just show you a couple of tips how to use a guide liner. So the best is to use a balloon and get the guide liner on the balloon, inflate the balloon, then gradually deflate and pull the balloon back, and the guide liner just dips in. But unfortunately, I couldn't get the guide liner across this bend. We tried very hard to get this guide liner down. I just couldn't get the guide liner down. So we had now exhausted all our resources. We had used a rota ablator. We had used a high pressure balloon. The high pressure balloon did not show a clear-cut area where I still thought there was a waste. And I had a guide liner which went up to this region. So I was completely exhausted. We had already spent 1.5 hours trying to struggle to get this lesion improved. But we were able to cross both the lesions with the balloon. And finally, this was the balloon result. So after 1 hour of struggle, we got this balloon result. And we took 2 shots in 2 different views. Though there is residual stenosis, but the flow was good and there was not dissection. So we were thinking that this is the best time to leave her, maybe call her once more a little later and think of using a Shockwave balloon because we were not prepared to handle this at that time with the Shockwave balloon, and then go for the LED and both lesions after that because we had struggled to get the stent. So we left this patient at that point in time, and she went to the recovery with a TIMI-3 flow, no dissection, with residual stenosis. However, she collapsed in the recovery room after an hour. She had VTVF, severe crushing chest pain, marked ST elevation, had to be given brief CPR, took her to the lab. Fortunately, the lab was vacant at that time. With inotropes, adrenaline, got her back to the lab. And now we have no option. We don't have the Shockwave with us. We know the artery is occluded. We have to get the stent somehow. We have to devise some other strategy to get the stent. So what we knew we had failed, we need to change the strategies. So this is the diagnose, the artery is occluded. We have to get the stent. Be required, we have to get the stent. So first thing I changed was the guiding catheter. So this is a 7 French guiding catheter. You can see the contrast leak into the ostium because we had created Can you see my screen?
No.
Okay, I'll share it again.
You share it again. We lost your voice for a while also.
Yeah. So I had to do things differently. The thing different was use an Amplats guider, which was 7 French, and wired this lesion. So this first wire was a BMW wire. The second change we did was took a long compliant balloon. I was very confident that if I take a long balloon, I will make sure that I will have left no area, and kept it for 1 minute. We kept that balloon for 1 minute so that we significantly close all the dissection flaps and are in a position to stent, the best stent that could possibly have gone there. And then was simple, put in another stent, and this was the final picture. This is the good result. We got her back after the 3 days. The lesion was stable. We went ahead and stented the LED. This was the LED result, which was also quite reasonable. So the lesson here is that calcium is your biggest enemy. Don't start a case until you are confident that you have everything that could it take to get your case going. In this patient, had realized that the RCA was a tougher lesion because of the angulation in the calcium and would give us all the difficulties. Fortunately for us, we were able to get the change of guiding, and 2 wires help us change of strategy, because you can't keep continuing to do the same thing over and over again and get into the same problems. The second time we had no choice. We had to stent it if we had to save that artery and the patient. The patient would not have survived if that artery had closed in the night, or if we had left a closed artery and thought that intra-aortic balloon pump is going to help her. It wouldn't have helped. We knew that. So we had to stent. A change of strategy of using a different guiding, different wires probably helped. Use of compliant balloon, keeping it for a long time, something helped, and we were able to push the stent, which was not going for more than an hour. We tried, we couldn't get it. Many stents were tried actually. So calcium, be prepared for everything before you start a case. You could need anything at that particular point in time. Is the biggest enemy in the cath lab. So if you see calcium, one should be prepared that this is a case where I'm going to spend time. Don't use it as a case where you say that this is a half-an-hour case. No calcium will be a half-an-hour case. So today's message of this cath lab complication is keep everything ready. You may need a rotor, you may need a cutting balloon, you may need an angioscult, you may need a shockwave, depending on what you want to use, but you have to have everything before you do such a case. Thanks, Nikhil.
Yeah, so I think that was an excellent case in for your teaching purposes, for how to handle calcium and how to not do what not ignore calcium, respect it. And I normally, when I have a complex lesion like this, where you have a multiple bends or you have a very tight lesion, a very long lesion, I tend to start with the smallest burr, which is a 1.25. And then like to up burr, so that normally helps out when you tackling these more complex lesions.
Nikhil, I did not, I'm sorry to interrupt you, but I'll tell you the whole story. We did with 1.25 burr. The balloon was not going easily. I had to escalate to 1.5.
That's okay.
That's what.
So you did start with the 1.25. So that is also generally, kind of, advice to people is that when you have a very complex lesion, you start with a small burr. Even if you say land up with a dissection sometimes and you not use the rotor to start with, you can even still use a 1.25 burr, and then rethink your strategy. Dr. Rustam, do you have any comments?
Yes, I was thinking about 125 burr that was actually shown in the beginning in the slides. The shape, it was 125. Everything was going well. The key in this case was to deliver the guide extension. And typically, if it is 6 French, I would use a 3-0 balloon. Of course, it will not inflate to 3-0, but I would inflate it there, and then while deflating, push the guideline or guide zero or another device just over deflating balloon, and do it multiple times. 3-0, once inflated, you will not be able to push in that lesion. Sometimes you need to take a new one to advance another centimeter. 2-0, for example, I don't know what was the size of your balloon. 2-0 would not work. because you need a bigger balloon to advance that device. Sometimes having 5.5 guideline, even though I prefer to use a guide zero telescope, may help on 2.5 balloon to advance. And of course, once the guideline is there, you can advance OPN, for example. That lesion would not be just enough to deploy the stent, because the moment you deploy that stent, it will not be good result long term, because the lesion is not prepared. So you've done rota, you've delivered extension guide, and then I would use OPN. If you have Shockwave, I don't have much experience with that, that would be another, but then it gets more and more economical if you're talking long term.
So we used a three. So Nikhil, 1 second. So we used a 3O balloon to try to deliver the Godzilla down, but the bend at that point, the calcific bend did not let that Godzilla go down. But
another thing is
it's very confident.
Another technique is, it's old technique, obviously. It's usually recommended only if you're going to stand that mid part, is to inflate that 3.0 that you have a bit lower, and then try to push your guide extension along, because you will dissect doing that, but you're going to stent it anyway. I agree with this kind of zigzag. It was very difficult. Of course, you need to go 7th range. You have to go femoral for these cases. Yeah.
Any comments from any of the other panelists?
From Dr. Balbir, this is Dr. Umar. Fantastic case. I think the AL guide did the trick for you. The support increased and putting 2 wires, and then you could manage both the stents inside.
I would agree with that.
Okay, so if there are no more comments, can we move to the next Dr. Abhijit? I think he is next in line for this case.
Yeah, I'm ready. Am I visible and audible?
Yes.
Shall I proceed?
Please.
Yeah, I am Dr. Abhijit Shirke, Associate Professor, Krishna Medical College, Karad. This is not a coronary case. This is like something different, which I have encountered in my life first time. First of all, I hope everybody is safe in this COVID situation. So that was actually end of my day. I finished my all procedures, and medicine resident came running and showed this X-ray to me. He said that this is a 20-year guy presented with a chest pain and dyspnea. His blood pressure was 70 systolic, and he showed me this X-ray and said, "Can you do something for this guy?" So he was a breathless, respiratory rate was 30, 32, and with the shock. And I saw X-ray. I thought, it was easily appreciable that there was a pneumopericardium. Frankly speaking, this was my first kind of case, such a case to see. And I thought I'll just aspirate and probably he will improve. So I asked him to take him to the Cath Lab. Before taking to the Cath Lab, I saw the echo. Echo was showing intermittent shadows. I thought he is a breathless. That's why I'm seeing this kind of echo. But later on, I realized this is a classical air gap sign which happens in pneumopericardium. So what happens whenever there is an air in front of the pericardium, right ventricle, then or visceral pericardium on the right ventricle, the ultrasound waves cannot cross the air, and that's why the heart is not seen in systole. And during diastole, the air will be shifted to the lateral side of the heart or lateral side of the visceral pericardium, and then ultrasound waves goes across the heart, and you can see the heart during the diastole. That was a typical air gap sign which was already presented in 1983 by Red et al. Then after taking detailed history, I realized he's a chronic tobacco chewer. He had a past history of poor differentiated squamous cell carcinoma of a gingival buccal mucosa, and he underwent debulking surgery, chemotherapy, and radiotherapy for the same. Follow-up PET scan was performed because he had some lesions in the lung, and the PET scan was suggestive of some possible metastatic lung lesions. So bronchoscopic biopsy of a left upper lobe bronchus was planned, and it was performed 10 days before his presentation. So I took him to the cath lab, and I could see the air shadow around the heart, and his BP was 70 systolic. I did a pericardiocentesis. I aspirated approximately 350 ml of air. But then despite that, neither patient improved nor the clinical or nor the fluoroscopic image improved. So then I stuck what to do again, because I thought just aspirating air will do a job. But then I thought I will have to see what is the cause of a reaccumulation of air. So I put a contrast in the pericardium, and then I realized that the contrast is going from the pericardium into the bronchus, and it was going into the left upper bronchus, and actually he cuffed out the contrast during the procedure. And then I realized whatever contrast I've injected in the pericardium has come out of the cuff. So in that time, I thought this is more of a pericardobronchial or bronchopericardial fistula, probably due to disease process or because of biopsy that must have formed. Then again, I stuck what to do next. So what I tried with the GR3.5 diagnostic catheter. I put a thermo wire across the fistula. I could engage the fistula, and I could cross the fistula and went into the bronchus. But what happens after going into the bronchus, that wire irritated the bronchi, and it caused cuff reflex and also bradycardia, which you can see in the fluoro images. And after cuff, everything assembly came into the pericardium, and then again I had to try this recrossing with the catheter and wire. But repeated attempts in a second crossing, I could not able to cross the fistula again. And then I thought I'll put contrast again, and I put contrast again, and I realized the fistula is closed on its own, probably by dragging the tissue while the assembly fell down in the pericardium, or probably I have dissected the fistula, and that has caused collapse of the fistula. Then I aspirated the air. My intention to cross the fistula was to put a probably vascular plug across the, to close the fistula. But then with that automatically it closed off. I could aspirate the air totally. Clinically, he improved. His pressures improved. His ECG also improved. And catheter pigtail was kept for 3 days. It was removed after three days. He continuously improved, and he was discharged on a 10th day of his admission. This was the X-ray on admission, where you can see the pericardial pneumopericardium. And this was immediately after the removing the pericardial air. You can see there is no pericardium, pneumopericardium. If you see the ECG also, if you notice the voltages in the limb leads and the chest leads, these are increased post-tapping, immediately after post-tapping. So causes of tension pneumopericardium are like a trauma, where there is a direct injury to the bronchi and the pericardium, or the formation of the fistula like bronchopericardial fistula, which happens in a patients with a bronchial carcinoma, or even iatrogenic procedures like a bronchoscopic biopsy. Few times gas forming organism which forms the bronchopleural fistula can form a bronchopericardial fistula. Then what are the treatment options for the tension pneumopericardium due to bronchopericardial fistula? When there is a communication between the bronchus and the pericardium, there are few treatments which are described in literature, like a surgical. You open the chest either with a video assisted, or you open the chest and close the fistula, drain the air, or you can go with the endobronchial stenting also, where you see the fistula and put a stent across that in fistula. But definitely it is not that easy job. And we tried some innovative procedure because patient was sick, he was in a shock. The surgical backup was not possible, and bronchial stenting facilities were not available at our place. Finally, we could succeed in this procedure, and patient survived through the procedure. So coming to the conclusion, bronchopericardial fistula with a tension pneumopericardium is rare and fatal, mortality is very high in these patients. Prompt diagnosis and treatment of such condition is important. Fluoroscopy guided transpericardial intervention is feasible, what we did in this current case. And this was the first reported case of a transpericardial intervention. Thank you.
That was a very interesting case. Yes, I mean, I don't think I've seen a tension pneumopericardium. Does anybody else have any experience on it?
Yeah, that was my first experience, and I thought it was just easy job to just aspirate air with the putting needle, but I realized it was something, a new bronchopericardial fistula. Frankly speaking, after reading the literature, I realized that there is a classical air gap sign. There are high mortality, very rare cases. Even such kind of procedure is also not attempted in the past.
Dr.
No, but
Bijit,
initially you didn't plan to put in a pigtail to start with?
No, I aspirated the air. And what I thought, immediately I just put a needle and I aspirate even 100 ml of air, he will clinically improve. But then I realized is despite aspirating 350 ml air, patient is really same, even fluoroscopy image was also same.
Dr. Bijit, hi, Dr. Umar here. How do you think the fistula closed? I mean, the tissue, the patient coughed and...
I have two presumptions. One is probably the catheter and wire dragged the bronchial tissues and it closed while it came with this thing. Or another possibility, probably I have dissected the fistula while going through the fistula itself, and probably that collapsed the fistula.
Okay, thank you.
Thank you.
The dissection of fistula seems more likely, but God forbid this would not have happened. What are the options? The panel is, I mean, I think let us discuss that thing also.
Would glue be an option, or I'm really not experienced with this?
Yeah, it's for the first time.
Less likely to be an option, because in glue you'll have to calculate the dead space very well and make sure that you're able to have a landing zone. The glue will tend to stall, and the other thing in the glue will be, if you're using glue, you have to withdraw the catheter in one go the minute you've injected your glue.
That's right.
Here the landing zone is not clear. So glue, I'll think the only option can be if you try to put in a bigger kind of a coil. If there is a money constraint, you can try and put in a coil. But even a coil staying in that area will only be available only if you're able to demarcate the distal zone. We don't know the distal zone, the area where you need to put the coil. It's been quite lucky that the catheter and the wire, probably the wire movement has dissected the mouth of the fistula.
Yeah.
But otherwise, trying a therapeutic option is going to be tough, because for any option, you need to have the end area where you need to actually put your the assembly. We are quite blind to the end area. So it's quite tough unless you know it. Glue certainly is not the right option, because...
So yeah, coils as far as is considered, I feel coil, if you are using, you have to use a detachable, coil, the screw one, because the usual coil which we use for renal coiling and bronchial coiling and, for some cases of coronary, once they are left, we cannot hold them back. And there was always a chance that this coil, if migrates proximally into the pericardium, what would it lead to? Never know.
Yeah, you're talking about the detachable coils which the neurosurgery people use, which are totally controlled by us. The detaching is controlled by us. Once again, understand the coil in any case in this patient. If you don't know the distal end, it is quite tough, because you don't know the size which you're going to use. But yes, if you inject again, and if you're able to see a zone a little bit, then you can try coiling. Certainly glue is not an option. That one option doesn't exist in this case, because glue will tend to, we don't know where to park it. And the glue, if it tends to float out, you'll not know where it has gone, it will cause thrombosis. And the function of glue, all of us, just for the sake of discussion, you'll have to use the sandwich technique to deliver glue anywhere. That means you find out the dead space of the catheter, make sure you replace all the blood in the catheter by dextrose, put the glue, put dextrose again. Because the glue, as soon as it will come in contact with any blood, will just solidify there itself. If your catheter is not clean, and in this case, you see the catheter has a very tortuous course. If you must make sure that your catheter is absolutely clean if you're putting the glue, and then use the sandwich technique. quite a tough thing to do in this case.
Yeah, so that's the reason I brought up the point.
You have to remove the catheter as well.
No, you'll have to pull the catheter. You put the glue immediately pull. Yes. Otherwise, it will also get stuck up there.
Yes, yes.
And in any case, it's not a good option because you need a drain subsequently also.
Yeah.
Okay. So we move on to the next case, which is Dr. Deepak Katyal, stent dislodgement of fearful recovery.
Hello, good afternoon. Am I audible? Am I audible, sir?
Yes, you're audible. Okay. Please go ahead.
Just give me a second. Is the screen audible, sir? Is the screen visible, sorry?
Yeah, your screen is there now.
Okay, sir. So I'm presenting a case of a 75-year-old male, sir. He is hypertensive diabetic on regular treatment. He had passed CAD with status post PTCA to LAD and L6. This case was done by me in 2017, and he had this old LAD L6 stent from 2011. He came to me with class 3 symptoms with a normal LVF and was planned for an angio. So on angiogram, the positive findings are that his major OM had a 80% proximal lesion, and RCA was proximal to distal diffuse disease with a proximal discrete 90% lesion. At this point, I would like to admit that maybe I missed some fluoroscopic calcium, which was there in the proximal RCA segment, which I saw retrospectively when I landed up into the complication. So the advice to him was multivessel PCI with stent to RCL6, and the second option in view of diffuse RCA disease and a normal or a flowing LAD was maximal medical therapy. So I'll come down to the basic complication initially here itself, because I did not have the cine images at the aortic root. So this is what happened to the stent. The L6 to OM PCI was done uneventfully, and then we engaged the RCA with the 6F catheter. I wired it. RCA needed 2 stents. The distal stent was deployed uneventfully, and then when I had to take the proximal to mid stent, the second stent, it was a long 2.75 into 35 millimeter stent. So initially the stent would not go, and then I ended up, the usual way. The first one had gone so easily, so this should also go. So there was a bit of push and pull involved, and suddenly in one pulling movement, I saw this happening in front of me, that the stent got stripped. I think it got hinged against the calcium spur in the ostial RCA, or maybe a deformed strut got hinged against the ostium of the guide. And then the stent got stripped from the proximal marker towards the distal marker. And this is a 35 millimeter stent which you see on the screen, and it has got totally crumpled up and kind of accumulated at the distal end. The reassuring part was that the stent was still, some part of it was on some part of the balloon. So this is what happened. So at this stage, what were the options that I had? So maybe call for a surgical backup, or deploy the stent at the last location, and as the stent is still on the balloon. As a precautionary measure, what I did was that I had pulled the stent into the right subclavian artery, so to prevent it from embolizing. And the other option would be to take a femoral access and snare. So with these options, I was already back into the right subclavian artery. I decided to pull it further. I'll first show you the angiograms of the RCA. Yeah, this is the RCA just after wiring. This This is the second. This is the first stent, which went quite easily actually. It's taking a while to play actually. Yeah, this is after the deployment of the first stent, and this is where I had pulled the entire stent balloon assembly into the we can say the radial artery. I was working through the radial route, and I had a 6F sheath with a 6F guide, and the thing would not come inside. So at this point, there were not really many options. The stent would not get pushed; it will not get pulled inside. So, can we have a bit of discussion what we would have, done differently, or what we should have done ideally?
Any comments from the panelists?
So what size of balloon is this?
So this is a 2.75-35 stent.
And what is this balloon? 2.75.
Yes, a 2.75.
So the best option would be just to inflate it on a low pressure and pull the whole assembly out. The whole thing will come out.
Inflate the balloon?
The balloon, just because it's stuck in the sheath, this part of the balloon is in the sheath.
So
right?
There's a crumpled stent ahead of it. The stent has got stripped from the proximal marker and got crumpled. And
so the balloon shaft is still there. The part of the balloon is
still there.
So if you inflate the balloon, and you would be able to get the whole thing out.
Otherwise, you can always do 1.5 balloon 2025 sequential dilatation and just leave it there in the radial.
You didn't have the scope of inflating it there itself. Was it still in the RC? Was the overlap segment? There was quite a lot of overlap. But what was inhibiting you from inflating? Because part of the balloon was still there.
The stripping off of the stent has happened when I was, just pulling it back into the guide, and the distal edge of and the proximal edge of the stent got stuck at maybe the guide ostium and got totally stripped off. So when I realized it has happened, my guide was floating, and the distal marker of the stent was just at the RC ostium. I was not in any position to push it because it would not go inside again. So I had to pull it into the subclavian, and from there again I thought to keep it down rather than keep it in the subclavian.
Once in the subclavian, I think because you were working from the radial, you had a very good option to go from the femoral and snare it out. That would have been a better option in this case, because trying to snare it from a radial would definitely be more difficult and more traumatic to radial. Since you had the femoral absolutely there and you were already safe having pushed it out, then you could have just taken a snare and a 5 RCA, taken a snare, and you would have coordinated in the subclavian, and would have been better to snare it from there. That's what I feel. The option, your option of saying that can I pass another wire alongside it is absolutely not a good option at all, because you will never know is the wire passing, which either passing through one of the studs and going back out of the stent. So you will never know. You cannot snare a stent by putting a wire alongside it. If you really want to do, because the scenario was that you cannot deploy it anymore. And the best scenario in this case, if you would have been femoral, put another balloon, which is around 2 millimeter, and try to take the assembly, as sir said, and take the assembly down from femoral. But since you have the femoral access absolutely with you, then I think the best solution is to go for a snaring from the femoral side, which would have been much easier, because then you could have held the stent from one of the edges, because you would have full liberty. You could take a larger gooseneck snare like the 20, so you'll have a better option, because in subclavian you have an area to catch it, unlike if you would have been just stuck up in the coronary. So the wise thing is to come in an area which is wider, and then I think snare from the femoral would have been a better option. That's what I think.
So maybe it was my lucky day, and I didn't want to complicate it any further. I work in a setup where there is no surgical backup, whether it is for emergency CABG or any like embolized hardware. So what I did was, just give me a second. I took out the 6F sheath and then I partially introduced the 8F sheath into the radial, like maybe the first 3 centimeters into the radial artery. Just give me a second more. The PowerPoint is got stuck. I'm sorry. But basically, I just upsized the sheath to 8F, introduced it partially into the radial artery, and like you saw in the last cine, that the diameter of the crumpled stent was almost comparable to the 6F sheath. But still, it would not just come in. So upsizing it to 8F, I could, with a gentle pressure, it just came inside the 8F sheath, and I took the entire assembly out. So it ended very simply, but it was a very fearful complication. I'm really sorry, my PowerPoint has got totally stuck.
Any more comments? Okay, so if there are no more comments, we'll move on to the next case.
Thank you, sir.
Which is Different Shades of Code Red by Dr. Sanjeev Kathuria. Are we ready, Dr. Kathuria?
Dr. Kathuria, you're on mute.
All of you can see the screen, sir?
Yes, we can see your screen.
Go to start. Just a second. Yeah, fine. So this topic of code red is because of code red in the cath lab, which happens when you have problem with respect to your procedure and you get stuck up and you need urgent help. And for us, most important thing is a perforation. If you're doing a procedure and you get stuck up with a perforation, it's one of the kind of code red for us. But what I have put the topic of different shades is because even in a code red, you can have situations we have been bailed out by some specific method. What I wanted to really show here is that most of these cases, once you have a perforation, because after a stent, what I have seen is that the perforations post stenting, that they tend to seal if you give time for balloon tamponade. That's what I wanted to show. So I'll show 2 cases and then we'll discuss it out. So my first thing I really wanted to say was that if you don't have a perforation, that means there is something wrong with your technique. So this was a 60-year male, hypertensive, ex-smoker, had a past history of inferior wall MI, now came with crescendo angina, ECS episode 15 days back, was having RWMA in the LED territory with injection fraction of 40-45. So this was basically his LED territory. So what I decided was that we'll first tackle his LED, thinking that this coronary syndrome is because of the LED, and probably because he has a totally viable RC territory also. We'll go ahead and do the RC as and when required later. And we did the normal wiring, which is done, and along with that, a ballooning, and then we did the stenting of the distal part, followed by the stenting of the proximal part. Now, this is an important part. See, we've used it, as far as I remember, a 2.75 stent, and this is what happened. So now there are the issues I really want to discuss here are that there are various techniques which you can use. You can think of what is propagated as a ping pong technique. Immediately go for a pericardiocentesis, do the haemodynamic profiling, see your coagulation status, get another guide from the other groin, and make sure that when you're doing a balloon tamponade, you don't lose even 1 minute of any leakage of the of the perforation. But the problem here was a little different for me. One, you see this person has a lot of dependence on this LED. Also the fact that my guide, when I tried to, I've omitted a lot of shots, but when I tried to intubate the guy with the 6-up guide also, I used to find a little ventricularization. So this being a very large perforation, I decided that I did a balloon tamponade for some time, but there was absolutely no stoppage of, there was absolutely no change in the status of the perforation. This is the balloon tamponading I've been trying. And after that, I took a stent graft. This was a 2.8 19 Abbott stent graft, the graft master. And ultimately, by God's grace, we were able to totally seal the, it was not 19, it was 26. We were able to seal the perforation. Now, my basic purpose of showing this is it's a normal thing that you are using a stent graft to seal the perforation. But the thing I missed in this case was this thing. Can you see the bend in the LED? I found it extremely difficult, and I must say that I was very lucky that the stent graft went there. But since I was working in the PA cranial view after having taken the yellow corded shot, I missed this absolute approximately 180-degree bend. That is why I found it very, very difficult to take a stent graft here. The option of exploring for putting any kind of coil was there because we had everything on shelf to put a coil. A microferret was there, a 018 coil was there, a SV5 pusher coil wire was also there. But the problem was that I didn't want to coil a viable LED in a person who was already had an RC which was totally 100% occluded. Now moving from here to another case, I like to discuss a little aspects of this case along with this case. This was a 54-year male, post-stented to RCA, had a history of ACS once again, and came with ECG T-wave inversions in inferior lead and ejection fraction of 40-45%. First of all, I checked for his RCA stent, which was flowing well. And then we went ahead and saw the left angiogram, which showed a lesion in the L6 as well as a lesion in the LED, but I decided to address the L6 first, considering the fact that there were changes in the inferior leads and the TIMI flow, those decreased in both of them, but I thought that L6 was the first thing to address. And this was, I've omitted all the other, this was the stenting done. And this was what happened. Now in this, luckily I had the option because I have other arteries flowing. So I had in my mind, first thing, the difficulty was I didn't have a stent graft at this time. I also had the option that I thought about coiling the L6. The first thing I did was the balloon tamponade once again, and ping pong technique. I took the other guide. I made sure that I have the other guide in place. At the same time, I was searching for a stent graft. I wanted to do that. But with the coil also, the problem was I didn't have a 3mm coil. The first coil available of 018 was a 5mm coil. So the technique of wait and watch with the balloon tamponade, which we normally follow, which is said to be 5 to 10 minutes with around 8 atmospheres. I kept that, and I was trying level hard from all chambers to get, from all quarters to get the stent graft. In the meantime, I deflated it for some time, and then in the meantime, I made sure that I've passed another wire from the other guide, so that if I do get a stent graft, I should not be wasting any time. And after a balloon tamponading for at least 20 minutes, I think, because that was the time I was not able to, this is the result. There was absolutely, the drain which had come, I have already drained with the pericardial synthesis, but this had absolutely closed. And I did a check angio maybe 7 days down the lane, and the artery was flowing, in fact, flowing much better than this. And there was absolutely no collection after 2 days. I just want to discuss this. All of us know this, both of them were a type 3 perforation. Another classification of perforation has come where, had this been a leak into another cardiac cavity or there is a distal perforation, then the whole outlook of looking at the perforation changes. I have taken, these were 2 original cases. This I have taken from the net just to show that this looks to be a very ghastly perforation, but this is actually a septal perforation. So I just want to discuss some points about it. If you see, your perforation can be at different points. From the main vessel itself, you can have an epicardial perforation while doing while chasing a collateral in the retrograde, or you can have a septal perforation, which is dependent on which of the collateral which you have chosen. In our case, this case which I showed last was a septal hematoma, which is mostly because of septal perforations when you're trying to get into an LED from the RCA and in the retrograde route. So these septal perforations, they can tend to settle also on their own because you have a contraction which happens, which tends to squeeze them. And sometimes they can get aggravated, cause some blocks. In that case, you might need to tackle them. My take-home message is very, very clear. You keep the anatomy, the clinical scenario, and the physiological significance when you're handling them. You have the ABCs of perforation, which I'll tell, which you have to follow. But then you need to see which part of the artery. Is it the distal perforation, proximal? Again, physiological significance of that artery in that person, whether you can absolutely close it or not, and the anatomical variant where you're trying to put your stent graft. You should know that the anatomic, because that is why stent grafts in the proximal arteries are good. You can use the ping pong technique. Remember, when you've tried to close it, make sure that you've checked it from the other vessel also, because you can have a supply from the other. This is something which I have not from the literature itself, but this is what I've seen in the hospital also occurring. Post-stent perforations, you apply weight and watch, they tend to settle. Remember, stent graft is a very heavy assembly, so it might not be feasible to deliver in all anatomies. And in this case also, the anatomy was quite unfavorable, the first case which I showed, but luckily it went through. The ABC of perforation should never change. Always keep your cool, don't panic. Remember, you start the balloon inflation, maximum 8 atmospheres, maximum 10 minutes inflations, repeat 5 to 10 minutes. Coagulation status should be stabilized. Try to get it to below ACT. Once again, this is a very debatable issue. If you have put the stent, is it that you should totally reverse the heparin? Is a totally controversial issue, because you need to again see which part of the artery are you actually in. Are you near the left vein? Are you in a very distal part of the LAD? Are you in the distal checks? Drainage, pericardiocentesis. Then you can use the endovascular treatments, the grafts, the coils, the gel foams, the PUA particles. And then we are talking about the glue. The glue obviously is an option, but you should have good experience enough to use a glue in a situation, because glue would mean you should make sure it is not in the proximal part, also to make sure it should not tap into any of the arteries, also to make sure that you must withdraw the guide, otherwise your guide will also get glued. Obviously, surgery is the last option. So in an order is balloon inflation, coagulation, drainage, endovascular treatments, glue always by the sandwich technique, making sure you have displaced the whole blood, and always glue with dextrose in a syringe. Make sure you take some amount of dextrose, then that amount of glue, then again dextrose, then inject, because the first thing which will go into the guide will be the dextrose displacing blood. The glue reaches its spot, again dextrose pushes it, and you take out the glide. Right. So this just shades of code red, just trying to show that there can be situations where even with the balloon inflation with such a ghastly perforation, you're able to bail out, but you must keep everything in place, especially 2mm coils, 018 coils, and your microferret in place, along with the stent graft, of course. If you're not able to deliver, then you can use this option.
Thank you, Dr. Sanjeev.
Yeah.
You have comments, Dr. Rustam?
Great cases, Dr. Katuri. The first case, it worked through that proximal zigzag kind of turn. As you say, luckily it worked. If it didn't work, that would be a difficult case, as you cannot inflate for so long, causing ischemia.
Yeah, because of
I think in this case, I would just, as you had already the second guide, I would probably balloon it, and then at some point take the balloon out, quickly put a stent proximally to straighten the vessel, big stent, and then rewire tamponade, and hopefully through that straightened segment, the graft master will go. We had graft masters up until 2 years ago. Now we have papyruses, much easier to deploy, and few other brands available. The question is with second case. Second case is really also circumflex AV groove there. It worked with just tamponade, never worked with me, but I see it all the time on the conferences. What would you do if you didn't have the graft master or any other brand? In China, they showed me the technique of putting tegaderm around normal stent, just one layer, so it expands. I don't know if you have experience with that. You probably have in India, but good techniques to know if you don't have covered stents.
I think in that case, because once again, the physiology of that case was difficult. A big, huge RC doing well. LAD, which in that case could have been stented after doing a coiling of L6 also. In that case, the physiology allowed us to have a little maneuvering because of the fact that you have an RC flowing and LAD which can be stented. In that case, even if the stent graft, though it is a good place for stent graft to go because it was quite straighter, if you're not able to get a stent graft, in that case, coiling would have been okay. And then make sure in that setting, do the LAD so that you're able to get some hemodynamics back because the ejection fraction is 40-45. So each artery is contributing.
Dr. Balbir?
Yeah, so I have a point. This coagulation business, there is a debate whether you should reverse the heparin effect at that stage or not. I distinctly remember one case 3 years back where there was a wire perforation and we had to coil it. And the first reaction was to reverse the heparin, which we did and got the ACT to about 120, 130. So it took about half an hour for the perforation leak to settle down. And when everything settled, we realized there was a big thrombus sitting in the left main. And we had to now tackle a worse situation of a left main thrombus. So most situations, I would think reversing a heparin may not be the right unless you are sending the patient for surgery. If you're still working in the artery, thrombosis is very much common and should be avoided at all costs.
So this is something really I wanted to discuss in this forum. The basic problem is if this has happened, if you have not put the stent, then reversing heparin might be an easier issue. But if this has happened with your stent in, then there's a very, very, very small bracket to work with. Because now if you reverse heparin, you are inviting thrombus also in that stent. So I think it's a very, very gray zone. But if it is beyond stenting, if stenting has not happened, then I think it is quite okay.
No, I'm telling you a case which stenting had not happened. There was a wire perforation. We coiled that wire. It took half an hour to do the entire coiling. There was a thrombus in the left main.
Yeah. Still it stays. I think wire perforations, I think are much, going into stage 3 in a wire perforation is less likely to happen. But though I've seen some wire perforation, they manifest hours later. You've shifted the patient, hours later they do manifest.
The question is that, reversing heparin may not be the right decision.
Yes,
if you're
absolutely.
Working in the lab and trying to save the patient.
Yeah, so that's why I said coagulation status to be stabilized. It doesn't mean that you reverse it. You'll have to really balance it. If you're working in the osteal LAD and this has happened, I think reversing heparin.
Your slide said ACT less than 160. I think that may not.
I would tend to agree with you, Dr. Balbir. And in the first case, I should have probably done the RCA first. That is, of course.
That thing I would address once again with the fact, sir, that his inferior MI was 3 years back. And this time, he has been admitted with a fresh ACS. And the 3 years, he was not bothered. He had an MI. He's taking medications coming every day. So probably I thought that his acute coronary syndrome is LAD. I was absolutely sure that RCA needs to be addressed. But I thought it's the crescendo, the angina which has set in, or a person who is not bothered for his symptoms of 3 years because of LAD.
Okay.
Because that could have been, that is another scenario of attempting an RCA. But with an LAD which is hanging and attempting an RCA, I thought it would be much better to help myself with getting the LAD done and probably take care of the RCA later.
I agree, Dr. Katuria. LAD was probably the first choice to do, and patient probably would become asymptomatic since then. Quite good collaterals, nothing needs to be done. And then the collaterals can even grow and potentially if symptomatic, and then
give me the bilateral
can do the right.
And give me the help of the bilateral injection for an RC. That would also become much more helpful.
Yeah.
Yes.
But I agree with Dr. Balbir that I wouldn't reverse heparin unless I already deployed coils and the case is done. If I'm still working, I prefer just have pericardiocentesis and keep working on anticoagulation because equipment is still there. Once either either special technique is performed or coil is done, then it's okay. I think if there is no stent, because dealing with thrombosis of equipment is a big problem.
Which coils do you prefer? The 2 millimeter, 3 millimeter O18 coils with the microfarad?
Oh, you said you had 5 millimeter coils there.
I had 5 millimeter, yes. Sir.
Anything bigger than the lumen of the vessel is fine because it will not go down. You can just deliver it. In my lab, I don't have 014 coils. I have 0018 coils.
We have
that
018
I routinely use via a fine cross, which is 0014. That's the only 0014 catheter, microcatheter that works perfect with Tornado or other 0018 coils. Very comfortable, just pushing with the soft tip of the BMW.
Absolutely. But I'm not talking about the breadth of the coil. The 5 millimeter coil was 5 centimeters also. That was the problem. It was a 5 millimeter, 5 centimeters. So my concern was that
no,
since
that's fine.
I'm putting a coil, it can go into towards the left main.
No, if you have the tip of the microcatheter at the lesion and you control it there, that would be still fine.
Yeah.
You'll just make a circle knuckle there and it will just stay there. But you have to make sure you're not losing microcatheter, because if you lose, the coil will spring all the way to left main, and that's the problem.
So the concern was that the area of microcatheter was quite less. It's quite in the proximal part. So my concern was exactly that. If I get a microcatheter which pushes back because of the coil, then the coil length will come into the and this LED is already hanging. So then it will be a much more a tougher situation. So best was to make sure that you get L6, close this L6 by some other method or get a smaller coil. So make sure LED keeps going.
Dr. Sanjeev. That was an interesting discussion. Dr. Sanjeev, thank you so much.
Dr. Sanjeev, just one point, if you allow Dr. Nikhil, please.
Yeah, please.
Dr. Sanjeev, fantastic bailouts. I just want to know what was the stent which you used in the first case, because
if I remember correctly, see, it's quite long, but I think it was small Yukon followed by a Nova stent, the one which perforated.
Actually, there's in a few cases I've seen if it's a ultra thin stud stent and there's a bend, so the force while inflating the stent goes at the angle of the bend, and sometimes the force is transmitted at one point and leads to a perforation. Just an observation I've seen in 2-3 presentations that the stent studs, if they're very ultra thin, the force transmitted can be at a one particular point which does not open and can lead to perforation.
Perforations in stents are mostly from the edges. Mostly they overlap stents or the edges. They tend to, but I'm not sure about whether the thin strut has any role to play in kind of perforations.
Well, we suppose you had a bit of calcium there, and then you try to post dilate it, and sometimes that's when the middle of the stent, that the perforations do happen at the shoulder of the at the junction.
Right.
So we have interestingly 1,550 viewers watching this meet as of now. So these are the statistics I got. So I thought it'd be pretty interesting to share with everybody. So this is like a very big meeting. Okay, so we have the next presentation, which is Dr. Ashish Singhal. Are we ready, sir?
Sir, can you hear me?
Yes, we can hear you. We need to get onto your screen.
Actually, the problem is with my net connection. I cannot upload my video, otherwise the slides and audio won't come to you. So if I turn on my video, the network connection.
Sanjeev, you will have to stop sharing.
Yeah, yes, sir. Yes, sir. Yes, sir. Yes, sir.
So
my
list. Yeah, you're on.
Hello.
We can see your screen now.
Can you hear? Okay. So right now I'm starting. So my good afternoon, panelists. Myself, Dr. Ashish Singhal. I'm working as a consultant cardiologist in a small hospital in Rohtak. So I'm presenting a Cath Lab Nightmare which happened to me when I went to do a case in a small peripheral setup in another one which I'm not working in a late midnight where my colleague was not available and I was doing a proxy case for him. So the title of the case is myocardial infarction. So its story belongs to a 55-year-old female. She presented in the emergency department with acute onset chest pain of MI. Then vitals was relatively stable. There was no known cardiovascular risk factors, and the lab parameters was also normal except the TLC, which was slightly raised. ECG showed typical anterior wall MI with estimation in anterior leads. Now, it took around 30 minutes for shipping the patient from emergency department to the Cath lab. And during this, the patient had a hypertension. And she was started on dual line support of norepinephrine and dopamine. That was prominent with diffuse part with a maximum of 85%. And you can see there is extensive disease in the LED. LED was basically this complex coronary artery section. It's light from the LED into the LC, even reaching up to the left cortex sinus, and the complex was also having a lesion in the proximal.
Your voice
So
is cracking. You need to do something to your mic. We can't hear you clearly.
So what?
Your voice is cracking. There's some. Is your mic okay, or is it the connection maybe? But we can see your screen pretty clearly.
Okay. Okay. Can you hear me now?
Just go ahead. Just go ahead. Yeah.
Okay. So we proceed with the interval primary to the LED. We tried lighting into the LED and the wire, but the wire was not going easily because there's a flap. We tried lighting it again. We used 210 NC balloon support, and as soon as we keep on attempting, but that was not going easily. Somehow, after repeated negotiation, we tried we got some success in passing the wire in mid LED. We dilated, but we were not able to see further because of the not able to visualize the correct of LED. However, in we were able to fire the LED with the wire, and we passed the balloon. We dilated with the 210 balloon, and after that, we dilated it, and we can see there's a flow coming up with LED. There's only one flow coming LED. So after that, we started from the proximal LED with 324 different. The dissection almost sealed off. There was some sort of dissection left in probably in distal LMCA, and both the vessels were flowing fine. At this point of time, we thought that leaving patient here will be more better because we didn't want to just take a LMC but the LMC was very short, and we thought the dissection might seal off by itself. So we shifted the patient to the ICU. She was on dual anitropic support. She was kept on tirofiban infusion, which was continued, and the patient chest pain got relieved over the time, and ST segment elevation also settled down. Now, what happened after 15 months? The patient developed sudden onset acute chest pain, and the ECG showed left wall MI with a huge ST elevation, and suddenly the patient BP dropped to 60 millimeter of mercury. This happened around 15 hours later when I was not there in the city, and my another colleague was called in to handle the situation. So when he found out that RCA LED is flowing well, there was some decrease in the flow in the circumflex. He major OM, which is coming up from the distal part of the circumflex, there was almost one flow in it, and for that he did thrombosuction twice, did along with the balloon dilatation, but there was no improvement in the flow. The L6 was dilated with 310 balloon, but there was no improvement in the flow. And after that, the patient developed sudden cardiac arrest. We attended CPCR for 45 minutes, but the patient succumbed. Now, on looking back and retrograde, we've seen that the patient has not only the dissection in the LED, which was extended in the LMCA, but there was a dissection in the circumflex also. What we thought was of initial small haziness in the LCX was basically a spike dissection extending from the LMCA into the proximal circumflex and even into the distal circumflex. That what we missed. There was a big judgmental error from me and from my colleague, and that's why we lost the patient. So what went wrong was we should have inserted another stent in LMCA doing the bifurcation stenting. The LN circumflex should also be stented at the index procedure too, so that the other STEMI should be avoided. And we don't have any hemodynamic support in our setup, so we should have it in our lab. And we should have put on patient on continuous anticoagulant infusion. Hello?
Yeah.
Yes, I think my audio was not coming properly too, sir.
Yeah, but the case was well taken, and the difficult case, there is no doubt about it.
Actually, it was our judgmental error. We were not able to pick up that dissection in the circumflex. We thought it might be a simple clot, which might go away with a simple anticoagulation and all drugs.
Actually, the iliocranial view, even when you were not able to wire, when you were wiring that, showed a dissection from the left main to the entire circumflex, even that view, while your wire was still not in LED. So that is the time you should have wired the circumflex first and then gone for the LED. So circumflex had dissected with a guiding catheter right at the beginning itself.
I think one of the very
or it could be a spontaneous coronary artery dissection.
No, it's a guide. It's a guide.
I agree with Dr. Balbir.
I think one of the very important things to do from the very beginning was to take another view. If you are leaving an LED and the left main, you have a suspicion, you have not taken the iliocaudal view at all or any other view to confirm that. That I think is a very because you'll never actually know how much is the contribution of thrombus to this. You are working in the thrombotic state. So I think taking another view before coming out was very, very important. And once, as Sarah said, the dissection plus minus the thrombus was evident very much in the beginning itself only. And then very important thing to note in this case, it's a co-dominant system. You see your RCA, your L6 probably it's a co-dominant system. This is something which puts much more onus on you to make sure that as you have held the LED with a slow flow still there and a co-dominant system in which you suspect or expect any kind of problem, the L6, other views which have helped you to make your mind much more clearer before you come out of this case. That's what I think.
That's what our judgmental error, and I think I was in a slight bit of hurry at that point of time because of some personal emergency also. So that's why we are not able to manage this case properly.
So I think that was a very important point which was brought out. So I think make note of it. We hadn't heard from Dr. Manjunath. Sir, you have any comments?
Thank you, sir, for inviting me. But actually, this is a very nice of Dr. Ashish to accept that he had made a judgmental error. And as such, that when the diagnostic angio had clearly shown there's a large amount of thrombus in the circumflex. So leaving it and only tackling LED is the main reason for the event to occur.
At index procedure, what do you suggest? We could have stented the LMCA LED with the bifurcation stenting and put 2 long stents in circumflex also, putting 4 stents or 3 stents at the same time.
So if I look back at the same pictures, if I look at iliocranial, it clearly showed the dissection had started at the left main and gone the entire circumflex. So if you tackle the proximal portion of the dissection, the other part heals. So you can't stent the whole circumflex because the whole thing is dissected. So if you stent from left main to the proximal circumflex, you would have probably salvaged the situation. That's what I feel. Rustam, you were something.
Tackling distal circumflex won't cause any problem if we seal the proximal thing.
You have to seal the origin of the dissection basically. So if you put a stent from where the dissection has started, the distal vessel will automatically heal.
So that point has already been made.
I agree. Right from the beginning, there was signs of left main dissection. So ongoing injections, obviously. Surprisingly, that it didn't progress too much visible to the end of the case. So yes, if it was noted early, maybe left main stenting would help. But I think LED, myocardial infarction, and then complication by the guide, I think, yes.
Okay, thank you everybody. And thank you, Dr. Ashish. And I think it's pretty gutsy of you to bring over this case and,
we should appreciate that. It's really,
we all appreciate it.
Yeah, and I think the aim is to, it's a teaching experience. I mean, it's a learning and a teaching experience. Both are important. So Dr. Vikrant Vijan, are you ready with your case?
Thank you.
Yeah, so can we have you on? But Ashish, you need to say something?
Thank you, sir. Thank you so much for the guiding us. And I think probably it was my one of the worst case that I have done, but I brought it up in this platform just to learn and to showcase that what mistake I have done should not be repeated by someone else.
Great. Thank you so much.
Thank you, Ashish.
Dr. Vikrant?
Hello. Good afternoon, everyone. Am I audible?
Yeah, you need to put on your screen.
Yeah.
Yes.
So, good afternoon. Can everyone see the slides?
Yes, yes, we can.
Okay. So I'm Dr. Vijan from Vijan Hospital, Nasik. This is a case which I done about 3 years back. And so in a government setup, a 77-year-old lady who's known hypertensive, diabetic, and she was referred with NSTEMI, clinically CLIP class 1, and she had anterolateral ischemia on ECG, and DF was about 45 to 50%. Tropi positive, we did her cath, and it showed triple vessel disease. So there was a borderline lesion in the RCA, and we had initially advised her cabbage, but patient was a vegetarian and she hated cabbage. So patient was shifted to the Cath Lab, and the plan was to do PTCA to the culprit circumflex and complete or staged as per situation. So we took a 7 French 4 guide, EBU guide, and we crossed this Cougar wire in the circumflex. And after initial pre-dilatation, we took a stent which was 3.5 into 18 from proximal circ, and again post-dilated with a 3.56. So I'll just show that. It was a good result. Just 1 second. Yeah. So this is the post-dilatation picture. Anyways, I mean, somehow it's not playing. So coming to the LAD, we did the lesion sizing with the tip of the Cougar guide wire, and it was a long lesion. So initially, after pre-dilating with a 2 into 10 balloon, we took a stent balloon pre-dilated with a long balloon, and thereafter we tried to cross a long stent, but we could not cross the stent beyond a 3 into 38 millimeter DES. As we can see here, the stent is not going forward and it is getting stuck. So I removed the stent and I again did pre-dilatation with a 2 into 10 millimeter balloon at higher atmospheres. And as we can see here, the balloon is going forward freely. We did multiple balloon pre-dilatations. So this time I tried to cross the stent again, and on retreat, the stent decided to stay back. So now we can see that the stent balloon has come out and the stent is inside. We tried to cross a 1.25 millimeter balloon, small balloon, but it could cross the stent, but it got stuck distally and it could not cross the distal end of the stent. On second attempt, the whole thing is out. The wire, the guide also came out. So after this, I tried to cross another fielder wire, but it could not go through the stent, but it went by the side of the stent. And with the help of micro and a snare over a microcath, I could remove out the stent. As you can see here that we have removed the stent. So good riddance, but is it really a happy ending? Not so. We thought that probably things will be okay after that. So there is one very good friend of mine, a very famous dialogue of his, which I'll be coming to in the next slide. So we have just reached the intermission. Now I took a check angio and I see that the guide wire has caused distal LAD perforation. The snare has dissected the ostial circumflex, double trouble. The BP started dropping and there was tamponade. So what I did was, there was a distal LAD perforation. I took the wire again and I took a 2 into 10 millimeter balloon, did balloon dilatation distally and also did pericardiocentesis for the tamponade. After this, I took a microcatheter beyond the balloon and I injected gel foam. So as you can see that it is getting sealed now, and patient's BP also started improving. Don't worry, no more Shah Rukh Khan is going to come now. And this time I thought I'll put 2 short stents, 3 into 24 and 3 into 20 millimeter stents in the LAD. The ostium of the circumflex flap, which was caused by the snare, was stented with a 3.5 into 9 millimeter DES and distally overlapping with the previous LCX stent. So this was the final result. Patient went home after 3 days. So just few take-home messages that you don't need to watch thrillers, play adventure sports. Cath Lab is enough. At the end of a complication, we should not chill. It is interventionalist's core responsibility to complete procedure and tackle all sort of problems that we face. A teamwork. Always keep a cardiac surgeon. In my case, my cardiac surgeon ran away when he saw that there was a perforation. The cath lab must be fully equipped with all gadgets. And please keep attending my worst case nightmare sessions. Patient had come for a last follow-up last year and she was tested negative 3 years later. Hopefully I see her again this year.
Dr. Vikrant, I think you got the name perfectly right. I think that was one thing which was absolutely spot on.
Status complicatus.
Yes. Can you have a look at the angiogram, the first angiogram, the diagnostic one, if you don't mind?
Yes, sir. Just a second. Okay, yeah. The first angio. So the circ ostium looks okay.
I was looking at the calcium in the LAD actually. Again, the same point.
Yes, sir.
Yeah, so this is coming back to Dr. Balbir's initial presentation.
Right.
So I think that is the reason you couldn't get your stent across.
We could not. Actually, sir, what I did was like I pre-dilated multiple times with the balloon that I had. In our setup, we don't have rota or any of these imaging. So first I initially tried with a 2 balloon, then with a 2.5 stent balloon, after which I tried to cross the stent and again pre-dilated with a small balloon again at higher, about 16 to 18 atmospheres,
So very nice case, Dr. Vikrant, very well done. So I have just one message to give, that avoid using a stent balloon, particularly long, to pre-dilate a lesion.
Yes,
you have problems that can happen. Problem number one is it's a compliant balloon, so you may not be able to open the lesion. Second is because of the compliance, you may rupture the vessel. So one should avoid using reused stent balloons as far as possible. And preparing a bed with a non-compliant balloon in this patient may have been a better choice than using that stent balloon.
True, sir.
Can I come in? So I feel if you see the next shot, if you're trying to deliver a stent, the most important thing when you're trying to deliver a stent, I think, is that your guide should have a very good support. You see, the minute you're trying to put your stent, the last stent which you attempted to put, your guide is hanging. Let's say it was hanging because it was pushed back, but the most important thing is your wire is not giving you enough support. You've put the wire in one of the septals or the diagonals, if I remember correctly. So the first thing which you need to do if you want to put a big long stent in an artery is that you'll have to get the wire deep in. And the reason they see your wire is quite in the mid part or maybe in the distal part, but you have a much more better anchoring zone available.
Correct.
Your wire should have been deep in if you're trying to put a big stent.
Yeah.
See, and the reason, and you see the wire and the balloon are two important things which will send your stent, whether you're pushing in a 48 stent or you're pushing in a 28 stent also. I think your guide is not giving you enough support. Your wire is not giving you enough support. It's one of the reasons.
So we try to deep engage it also. If you can see here also, we tried whatever you're saying, even jackhammering, slowly trying to engage. Probably the wire.
Throughout the time, you see your wire has not parked in the distal LAD, which should have been.
Right.
I think,
and
that is the reason you're trying to push the wire. Your loop has caught the perforation, because at that time your perforation happened because Now you're manipulating the wire with the stent in, so you've made the wire much more stronger rather than the maneuvering which is required to put it deep inside. I think this is what, and see, this is the reason now with the smaller balloon which is going, the wire is still now quite crumpled. And this is the reason I call it. And the other important message is, whatever is the situation, if you have lost a stent, never lose the wire which is inside the stent. That is your lifeline. Even if you have lost the stent which is halfway, your balloon is anywhere. If you have a wire across, that means you'll be able to maneuver your stent in some manner. But if you try to do a pull-in phenomenon, if you lose the excess of the stent which is hanging, that is a much worse situation. Very lucky and very good that you were able to snare this stent out. It was quite good.
Dr. Vikrant, it's an amazing case. 3 major complications, and you dealt really nice. One thing is the whole mantra of all complication sessions is, as Dr. Singh said, it's calcium is the enemy, respect the calcium. So yes, a vessel preparation would be, if it's better prepared, the stent would go. But in this case, once the stent is there, you potentially could wire circumflex. And because you're going to treat that circumflex lesion and just inflate anchor balloon there and try to push the stent if it goes, possibly. The guide obviously is a bit maybe half size smaller. It keeps backing off, but maybe that would help a little bit, just do an anchoring or guide extension sometimes.
I know.
But well done. It's 3 major complications and excellent result.
Yeah.
So all about your skills, how you manage this.
Okay. So I think that was an interesting case, and I think we managed to salvage the situation pretty well. We have Dr. Biswaranjan Jena with who got lost in a tunnel. Can we have you, sir? You need to exit your screen. Dr. Biswaranjan, are you ready?
I think so. You'll have to tell him to share the screen.
Yeah, so he's doing that.
Yeah.
We can see you, Dr. Jena. Your voice isn't coming through. You're on mute. Dr. Biswaranjan, you have to unmute your mic. Dr. Jena, you need to unmute your mic. Your mic is on mute. Dr. Jena, can you hear me? Your mic is on mute. Hello, Dr. Jena? Your mic is on mute, I think, what I can see here.
Yes. Am I audible?
Yeah, now it's okay. Your mic was on mute.
Yeah, sir. Thank you. So, good afternoon, everybody. Good afternoon, panelists. So here I will present my case. It's a 60-year-old male. He is a diabetic, hypertensive, and a smoker. Presented with N-STEMI. In echo, ejection fraction was 50%, and his renal function test was normal. So, getting to the angiography. Yeah. So, this is the angio of the left system. These are the caudal views. So, as you can see, the left main is normal. There is a lesion, circ ostium is normal. There is a lesion in the proximal part of the circ. And as you can see, here that OM was disease, and there is some disease in the LAD itself. So going to the cranial view, as we can see that there is a long segment, diffuse disease, starting almost from the ostial part of the LAD, means proximal part of the LAD to the mid LAD. The diagonal are also disease. So basically, this is a diffuse form of disease. And if I go to the right system, you can see this is a superdominant RCA, and there is a lesion in the distal part of the RCA also, just before the bifurcation. So this is the angiogram. This is particularly not my case. One of my colleagues was doing this, and what they have decided that okay, they will go for CABG. They have advised CABG to the patient, but some of the patient didn't want the CABG. So they went for the multi-vessel PTCA. That was the plan.
Can you please mute the mics, please? There's a lot of disturbance in the host.
So as you can see here, there is a 3.5 F extra backup catheter. It was engaging the left main. And what I asked them means I was not up to this slide. I was not in the scene. I was not in the cath lab. I was called for help once the patient was crashing. So when I get back to the cath lab, I saw this angio first. So what was there that they have engaged the EVU catheter. They have tried to negotiate a wire over there. Once the wire was not crossing the left main itself, so they wanted to see what is happening over there. So when they took the shot, when they took the injected the dye, here you can see there is a huge dissection starting from the left main itself up to the distal LAD. So this is the situation when I was called in. So obviously the patient was having chest pain, the BP started to fall. So the next option, what to do? So first thing was I could not afford to lose the guide position, because I thought that if I will take up the guide, then the left main is dissected. So there will be a flap or something. So and after that everything will close. So though the guide was a little bit inside the left main up to the ostial LAD, I kept the guide over there. We went with a temporary pacemaker. IBP we asked for, but somehow that day, unfortunately, the IBP was engaged in another patient and we could not get the IBP. So we continued with the inotrope support. So we thought that we'll inject the dye list, just because there is a huge dissection, probably guide induced. And after that, they have taken a shoot, and that has the dissection propagated up to the distal LAD. So search for the true lumen, that too with a workhorse wire. Imaging obviously is a choice once you want to know whether you are true lumen or false lumen, but in our setup that is not available. Then of course to stand the dissected part. So I started with the BMW where somehow I went up to the distal LAD, but as you can see over here, from here I could not cross the wire to the distal most part of the LAD. So what I did, that okay, I will take another wire as parallel wire, that is a BMW wire itself. So I tried to negotiate another wire to that tunnel or that dissected part to go to the distal part. I was surfing for the side branches because there was no imaging. I want to know whether I am in the true lumen or not. So the best part to know about that is, okay, if you are entering into the side branches, then probably you are in the true lumen. So that was the thinking process. I went ahead, tried a little bit, patient still on inotrope. So as you can see here, there is some progress. I progressed up to this, but with little bit of dye which I am injecting, there is no flow seen in the LAD itself. So here you can see I am in a septal branch. So I continued with the surfing. And as you can see here is in a septal branch, then here it is in a small diagonal. So after a few attempts, then I thought that, okay, I will see, because there is no flow, I will have a small balloon. I will have a dottering kind of thing, so that I will know that, okay, I can pass through the tunnel easily, whether I am in the true lumen or not. Once I have confirmed that, okay, up to the soft part of the wire, I am inside lumen, or the balloon is passing easily, then I thought that, okay, because from the previous angio, it's a tight lesion in the LAD, diffuse lesion. I thought that I will, with the same balloon, I will dilate a little so that I will have a passage. So here with that 1.5 into 12 millimeter balloon, I am having the pre-dilation like thing. So I thought that, okay, let's, if there is no flow, patient is crashing, I thought that, okay, let's see whether a stent can be, I can able to means deliver or not. When I'm taking the stent, as you can see, it's not going over there. So obviously there was the lesion that means I thought that, okay, either it's in a flap or whether there is still a significant stenosis sitting over there. I have taken a NC balloon of 2.5 into 12. I have pre-dilated the hole with that NC balloon itself. Then once again, I have done the daughtering with that same balloon. And then, as you can see, I was able to take the first stent inside the vessel. So here there is no flow distally. According to the bony mark in the rib cage, as in the fluoroscopy, I tried to think that where should I start, means deploying the stent. So with gut instinct, I inflated the balloon in the distal part. So after that, as you can see, there is some flow, but there is still no flow in the distal part. But that was okay at that time. I have taken the second stent, all are Giants expedition. The first stent was 2.75 into 28 millimeter. This second stent is 3 into 28 millimeter of Giants expedition. So overlapping stenting was done. Then as you can see here, this is the third stent covering whole the left main to the proximal or mid part of the LAD. So left main also stented. Patient still, if you can see in the next route, I see that there is still a dissection sitting over there. Though there was flow, I don't want to take a chance. I have taken the fourth stent to cover that part also. And after all that, we have done post dilation with respective NC balloon. And as you can see, this is the final result in the caudal and cranial view. Patient shifted to ICU. He was on inotrope for 2 days. Gradually, the inotrope support was decreased and patient was discharged. And as you can see that there is no septal branches visible over here. So probably I went true, then false, then true lumen, because here somewhere I can see the side branches. But that time the patient was crashing, no IBP support, no imaging support. With that, luckily the patient went home safely. He had a follow-up visit also, and there is some mild angina with optimal means anti-anginal. He is doing well. So what are the take-home message? To always follow the basics. Proper guide selection should be there. I think that there is a oversizing. That was not coaxial. If when it was engaged, we can see that if we review the angio, there is a tenting through the guide tip to the left main itself, and probably they have not checked the pressure itself because it must have shown some damping. Once there is a tenting position, then the guide wire selection should be good. You should manipulate as less as possible. In this kind of dissection, you have to minimize the dye injection. Then check your weapons. You should means you should have a surgical backup. You should have IBP. Imaging, if it is available, then that is always good, and you have to keep your patience. So this is how we get through that day. So this is light through the tunnel, and thank you.
Thank you, Dr. Jena. We haven't heard from Dr. Channa and Dr. Sanjeev Roy. Are you there, sir? Comments from the panelists?
I think it's a fantastic bailout, and I would have also kept a wire in the circumflex also. Tried to put a wire once you had a flow, maybe before setting the left main, maybe kept a wire in the circumflex in case the circumflex shut down. Just a point for discussion. Just a point for discussion.
That also I thought, but because that left main was so severely dissected and the guide position was beyond that circ, I thought that pulling it outside, somehow if there is a flap, then I will be in the soup. That's why I didn't do any manipulation with the guide. I went and that is circumflex was not that big artery also. So that in that way, I thought that okay, I will go ahead with minimal manipulation.
So did we do a stage procedure for the RC after that?
after that, actually, that time we have not done. And because with medical management, patient is now doing well. I asked the patient, but there are some financial issues, so we didn't went for that. But it's going fine till now.
Thank you, Dr. Jana.
Sir, can I come in for a second?
Yeah, please do.
Yeah. So I think the most important thing to learn, which you've already pointed out, is if you have a dissection, no antegrade injections, because that will only propagate the dissection. So if you want to see the wire position also, a septal or a diagonal, wire catching a septal or diagonal does not mean it is in the true lumen. Even in the subintimal, you can do that. The most important thing will be your feel and the anatomy, which you've seen previously. So compare that anatomy rather than giving any antegrade dissection, because that will just propagate the dissection. The reason I think the patient returned more was that you have lost the diagonal also in them. As the dissection progressed, a very big diagonal was also lost. Putting a stent when you don't have the distal vessel known is quite dicey, because had this been all in a dissection plane, that you have all dissected, you have stented all the subintimal planes. So unless you've seen the distal vessel, putting a stent is a little dangerous thing to do. One of the ways to see it is you put in a balloon, inflate the balloon, and pull out the balloon while deflating it. So that if there is a flap, the balloon will track along the flap, and as the balloon deflates, the flow will go. So one of the ways to see if you're not able to see the distal is you make sure with the previous anatomy your wire is more distal in, not by the branches, but by the anatomy of the wire, and start putting the stent. That is why you needed another fourth stent in the end, because you are never knowing where is the dissection ending. So try to take in a balloon, try to inject and deflate the balloon while you're taking it out. So you will try it, you will probably find the distal part of the dissection where you need to put it.
Yes, sir. Point well
taken.
taken.
The wire and the anatomy.
That's
no
right.
antegrade injection. That is the basic.
Yes, sir. That's the point when actually I don't know where the distally put the stent.
Yes.
But
that
there was
absolutely true.
Yes, sir. There was no flow, so I have to either give pressure to see whether there is a distal flow. I don't want to give injection in a full pressure way. That's the thing.
And then one important thing, even if you're giving an injection, let's say you're too much in a problem, your guide was still at the mouth of the left of the LED. So now, since you have the wire in, the previous concern was that your guide is not, you're not knowing whether the guide is taking care of the flap. With the wire in, take out your guide, so that even if you're giving an injection, the whole pressure should not go into the distal vessel, propagating your diet.
Yes, sir.
Dr. Rustam, you have something to say?
Yes, I think the whole teaching point of this case is what Dr. Katuri said, no injections. Like in CTO PCI, you can even disconnect the syringe or make sure automatic injector is not there. Even single injection can finish the case. Here, as you can feel with BMW and the distal lumen, all you have to do is just do full metal jacket if you have time, if the patient is stable. Of course, if you have IVUS, you do IVUS, but
that's right.
I guess you, for example, you don't have. And if patient is stable, still wire circumflex just to make sure. Otherwise, stent it and then only do injection.
Yes.
Obviously, it was guide was very aggressive. Initial guide, I'm not sure if it was change guide there, but the initial guide was just sitting there. But once it happens, not a single injection, just a single teaching point.
Any other points from the panelists?
No, everything has been discussed, I think.
Right. Okay, great. So we'll move on to the last case, I presume, Dr. Hiralal Pawar with Cath Lab complications, the night I couldn't sleep.
Discuss go out
Is the presentation ready?
Stop, sir.
Is Dr. Pawar here?
Sir, Dr. Pawar is not available.
Okay.
He's gone into a case. So
right.
We have the Q&A session.
Okay. So this is we got the last of the cases. I think it was a pretty interesting set of presentations and discussion. And I think first of all, thank the presenters for bringing out their nightmares. And we've learned a fair amount from this discussion. You need to respect your calcium, prepare your stent beds, the right use of the hardware, for example, not using a compliant balloon in a long lesion. And then, of course, having the right hardware on shelf. For example, one point where Dr. Rustam brought out was a papyrus covered stent. I think it's a very nicely deliverable kind of a stent, much better than the Graftmaster. And of course, glue can lead you into a sticky situation. And so I think we can take the panelists one by one and then final comments by the chair people. Dr. Manjunath, you have a comment?
It is a very great session and a lot of learning points. As you have summarized, Dr. Nikhil, I think the previously taking a stent balloon is
you mute, Dr. Saab.
Sorry. When the stent is not crossing, the option should have been a non-compliant balloon to take rather than the old stent balloon. That would have helped. And another thing is that suppose if we have the other newer modalities like Shockwave to make the bed, that would be better. The other important point is what was well highlighted is that not reversing the heparin effect when there is a perforation. That is clinically we should follow. And it was a great session. Thank
you. Yeah. Any comments from the other panelists? I think Dr. Channa, we haven't heard from him at all. Dr. Sanjeev Roy, is he there? Dr. Omar? Okay. Dr. Rustam?
I always enjoy attending complication forums. In Australia, we have 2 of them, one in Sydney, one in Melbourne every year. Then we have one in Hong Kong as well. What you learn on these sessions is how to be comfortable in uncomfortable situations, which eventually will happen to everyone. If the person does enough PCI. In our fellowships, in our early career, we learn how to be careful, how to prevent this. But eventually, with experience, we tackle more difficult lesions and the complications will happen. Be in control, stay cool, know steps that, for example, this kind of complications, I quite often go through my mind when you learn a language, like sometimes you make some dialects, train that. So similar, I would suggest to trainees, imagine this complication LAD, step 1, step 2, step 3, what you do. Very important, because this is not something you plan. This is something you try to avoid, but it just eventually will happen. Things will go very fast. And that's why it's important to go through your mind through the steps, just at your free time, I guess. Saving the patient's life by the complication you created essentially is very important. It's the patient's life. Great cases anyway.
So I think we come to the end of the session, and I think with the permission of the next lot of chair people, we can have the final comments from Dr. Balbir, if you don't mind.
Yeah, Nikhil, so it was a wonderful session. I really enjoyed every case. But the highlight is that we saw 2 cases of left main dissection, and both were extremely bad. So this is something which is preventable. So I think when we are doing the left system, we should be always watchful of the fact that this is can happen and can happen to everybody. So be on pressure, very gentle first injections, wire, and then take an injection. It's very simple things which can't be overemphasized. I know everybody in this audience knows this few things, but we in a hurry sometimes forget very simple things and end up in a disaster which takes much more time than what would have taken by just engaging the guiding properly and looking at the pressures. Gives you much more information than the whole procedure itself.
Thank you. Thank you. And I think we'll call the session to an end. And sorry, Dr. Sanjay Kalra, for biting into your time.
Right. Thank you all. I would request everyone from the first session to log off so that we can start the session on the hemodynamic support. So, good evening, everyone, for the second session of the BIC 2020. I'd like to welcome all of you to this session, Managing Complex PCIs Using Hemodynamic Support. I'd like to call upon Dr. Sanjog Kalra to take over the session and moderate. Welcome, sir. So you're on mute.
Thank you. Good evening, everyone in India. Good morning here in the United States. Good afternoon in Europe. And welcome to today's session on managing complex PCIs using hemodynamic support. My name is Sanjog Kalra. I'm the Director of Complex Coronary Therapeutics at Einstein Medical Center in Philadelphia. And I am very pleased to have a distinguished panel with me to help us through these cases and flush out all of the best learning points that we can. But before I get to them, I just want to say a quick thanks to our friends and colleagues in healthcare across the world for all the great work that they're doing as we fight COVID-19 and risk ourselves and our lives for our patients. It is our job, it is our creed, and it gives us all great pride to do what we do. And with that, also a shout of solidarity to our friends and colleagues in Kolkata, who right now are dealing with tremendously difficult circumstances in the setting of both COVID-19 and the recent cyclone that has hit the city and destroyed infrastructure everywhere. Our hearts and thoughts and prayers are with them. And with that, I'd like to introduce my co-chairperson, Dr. Praveen Chandra, who's the chairman of Medanta Hospital in Gurgaon. I believe he may be a few minutes late. And also my distinguished panel, Dr. Rajiv Dayal, who is the director of structural heart disease at St. Michael's Medical Center and assistant professor of medicine at New York Medical College. We've already met Dr. Rustam Dattaf, who is an interventional cardiologist at the Prince Charles Hospital in Brisbane. Dr. Viveka Kumar, director of the Cath Lab at the Max Hospital in Saket, and Dr. Ravindra Rao, director of TAVI and structural heart disease at the Eternal Heart Center in Jaipur. Welcome, panelists. I look forward to engaging with you, and I hope that we are able to get as much learning as possible out of this session. With that, and given the time, I'm just going to share my screen and we'll get to the first presentation, which is me. I'll be talking about potential ways forward for hemodynamic support and complex PCI for India. Thanks very much for the opportunity to address you all. So let's talk about a case to start. This is a 62-year-old man admitted with a non-STEMI who had a heart attack back in 2000 and then again in 2008 with previous CABG and 3 grafts, a lima to an LAD, a vein graft to a ramus and the RCA with an ejection fraction of 20 to 30%, who came in with an acute coronary syndrome. He was on maximal medical therapy at home. He had viable walls on previous testing despite his low EF, and he had an elevated creatinine. And so this was his diagnostic cath. You can see that there's tortuosity, there's a previous stent here in the mid RCA with some in-stent restenosis, and then there's some retrograde collateral flow up to a circumflex. There isn't much retrograde flow down the graft, so really there's no secondary support here to the distal vessel. In the left coronary system, you see that you have an open lima to the LAD, anastomose to sort of the mid to distal LAD with a little bit of diffuse disease in the LAD, but otherwise good runoff. In this LAO caudal view, you see the ostial LAD lesion, but no problem. We have a good open lima. We have this large circumflex branch, and then here's our trouble. We have this hazy, very, very tight thrombotic ramus, where now we have no graft that's functional. And you can see that this is a large bifid ramus that's supplying the anterolateral, or the majority of the lateral wall. Coming in late there. So these are our case hemodynamics. This is a guy with a heart rate of about 100. You know, as is typical of our patients in the cath lab, they're a little bit nervous, they're a little bit worried. The pulse pressure is sort of borderline, and that goes with his severe LV dysfunction. And he comes in with a non-STEMI. He's fairly acute. He still has discomfort. His PA sat's a little bit on the low side with a cardiac output of 4. His right atrial pressure is 16. His pulmonary capillary wedge pressure, or surrogate for LV EDP in the absence of MR, is 22. So he's a little bit full on fluid. His heart's not particularly happy, and he's tachycardic. Do we need to put support in this guy for this simple and straightforward ramus? Ponder that question for a minute as I take you through the case. So this was my plan. I planned to get in with a 7 French guide and have a venous line with a right heart catheter up to monitor the pulmonary pressures. And I made the decision not to use mechanical support in this case for quick PCI and quick pressors, which is what I think is not unreasonable given what we see on just the anatomy without necessarily taking all of the features into play. So I used a standard workhorse wire, got into the ramus with a Turnpike LP and a Pilot 50, and then as soon as I got the wire across, the heart rate dropped to 44. And the patient started to complain of significant chest pain. So as you can see here, I quickly ballooned up the lesion that I thought was the biggest problem. I inflated the balloon for 10 atmospheres for a total of 16 seconds. And he began to become extremely short of breath. Recall that his initial wedge pressure was 22. So at this point, I'm worried, okay? But I say to myself, as we all do in interventional cardiology many other times, I've got this, right? And ignored the crippling feelings of doubt as my patient started getting sick. I took increasingly higher pressures to try to open up the distal left main and make sure that there was good full flow, suspecting that maybe this ramus or this high OM was supplying a papillary muscle and I had just induced bad mitral regurgitation. Quickly opened it up. Still, though there was better flow, I called for extra hands at this point because the patient's not doing well. You can see all the movement on the screen. And this was the point at which we decided to put in hemodynamic support, recognizing that the patient's hemodynamics had deteriorated and he was getting into pulmonary edema. Anesthesia was called, he was quickly intubated. And these were my hemodynamics once the Impella had, once 10 minutes after the Impella implant had lapsed. His heart rate was up. His PA pressure was starting to get a little bit better managed. His wedge was still very high and his PA sat had dropped. And so even with the presence of hemodynamic support, albeit implanted as a bailout as opposed to upfront, we've just started to get control. This is because of the multiple boluses of phenylephrine and the patient's intrinsic catecholamine drive. And so cutting balloon angioplasty, a quick stent to the ramus and left main, and I've got it, right? This is my nice, big, juicy ramus. Everything's fine, flow's open, I've got a blood pressure. I felt real good about myself. Unfortunately, my patient went up to the CCU and he died 3 hours later because the shock hit that he took in this vascular path ended up impacting his gut. That's where the lactate of 7 that you saw was coming from. He declined quickly and he unfortunately died. So I must have been clearly wrong, right? I should have put in support. But was it really that clear? I mean, we all looked at the anatomy and said, this is a fairly straightforward ramus. This really shouldn't be that bad, right? And so this is what we think about when we think about who might or might not benefit from mechanical support. It's the classical CHIP or complex and high-risk indicated patient population, those with advanced stage and multiple comorbidities, many of which he had, those with complex coronary disease, so post-bypass, multiple grafts down, calcific lesions, and then importantly, those with severe LV dysfunction, like you saw in this patient with an EF of 20 to 30% with hemodynamic embarrassment. And that was the reason for which mechanical support, contemporary mechanical support, was introduced. Now, I'll limit the discussion here to the Impella, but it's important to recognize that there are other forms of support out there, balloon pump, you know, even inotropic therapy, and a number of others that are coming to market now. But this was the main definitive trial with using the Impella 2.5 device that looked at individuals with low ejection fraction requiring complex PCI and found that using the per protocol analysis, so this is the analysis with patients where they were actually analyzed by the treatment that they got, that there was an important difference in major adverse events when you used hemodynamic support versus a balloon pump. It was not quite significant at 30 days, but out at 90 days, it got out to 22%. And here at 90 days, it was 29% as per the per protocol analysis. And so then stimulated by those data, the post-approval study has now started becoming more important to our understanding. The data are starting to become increasingly analyzed. And in the PROTECT 3 post-approval study, we have the majority of patients now on the higher flow Impella CP device. And not surprisingly, with more support, you get a better effect with the recent data. So 90-day follow-up in PROTECT 3 showing big differences between the balloon pump with major adverse events in this patient population of 31% versus now down to 16.8%. So highly statistically significant, halving the MACE rates in individuals in PROTECT 3 using largely the Impella CP with some Impella 2.5. So clearly there's evidence to show that you can use these things in patients like this who are undergoing high-risk PCI. And that's part of the reason why the Impella 2.5 and the Impella CP have been approved by the US FDA for a fairly wide and nebulous set of factors, right? The high-risk PCI, which we're still trying to define, difficult hemodynamics, which we're still trying to define. And they've recently gotten rid of the idea of depressed left ventricular function, probably appropriately given that the anatomy of the coronary sometimes, as you can see, can dictate a lot more than just the ventricular function being down. But this is all nice in terms of whole overarching statements, but it really doesn't give us the granularity. Who really needs the device? And that's what we always struggle with, right? And this is the limits of how we apply evidence-based medicine. This is a slide from Dr. Spertus that I love using in my talks because it's so telling. Ultimately, when we look at evidence and we try to identify who's going to benefit from a given therapy, we have a trial outcome with a group of patients, those who are going to have a good outcome, those who maybe have some outcome that may or may not be a benefit. It's unclear because maybe follow-up's too short or there are other unmeasured confounders. And then those who do badly, these are the people that get the bleeding complications, for example, with large bore access, whether it's TAVI or Impella or even balloon pump. And so when we look at the treatment results, we homogenize them into this mean treatment difference, when in reality, what we want to do is optimally select patients, optimize our technique, our timing, and what have you, so that we can parse out that mean treatment difference and identify this group and apply the therapy to this group, the group of patients who are in green, those who are likely to benefit, while we avoid this group completely. And so what we recognize is that not all procedures are created equal. Not all patients or operators or even environments are created equal. Expectations of society, expectations of patients are very different, as you can see between how patients and physicians may interact in the Indian subcontinent versus how they might interact in Europe or North America. And so because all patients are different, this guy's a trifurcation left main and severe cardiogenic shock. This is a CTO of a mid-LAD with a hemodynamic support device, and this is someone with a borderline EF, but not terrible, with a long right chronic total occlusion, that we have to apply our therapies carefully in the context of not only our patients and what our patients need, but the nature of cases we have and the availability of resources within our market. I submit to you that in this graph from the Syntax study, nobody would want to get their CABG at this center with such a high MACE despite the volume, nor would anybody want to get their PCI at this center. So what we're trying to achieve is optimized use. And by balancing competing risks, so this is sort of the risks of non-CABG related major bleeding versus myocardial infarction on the one side versus the benefits of complete revascularization on the other side. What we're trying to do is balance the risks versus benefits of any of our therapy. And so when we try to think about hemodynamic support, we've got to start somewhere. So this is a spitballed algorithm, as Jamie likes to call it, my friend who put together a number of these slides and has generated some of the data. He and his colleagues put together this draft algorithm to try to understand who it is that should be supported and who it is that should not be supported. And they sat around a table and they decided these are the things that were important, that they felt were germane to their complex cases that might suggest the need for hemodynamic support. Importantly, they advocated right heart cath prior to going to PCI. And then they even put in detractors from putting in large bore access or hemodynamic support like PAD or a low hemoglobin, and developed a scoring system that suggested you really should support when people have a score of more than 4, and you're unlikely to need support when you have a score of 0 to 2. And then they retrospectively analyzed their own data. They looked at 77 odd cases with a mean age of about 69, a mean ejection fraction of 30%, chronic total occlusions in about 44% of their patients, so 34 people, and a variety of other factors, and they matched them to 85 consecutive non-supported PCIs in around the same period of time. And what this shows is that they were relatively consistent internally with how they conceptualized cases. Those with lower scores didn't tend to get supported versus those with higher scores tended to get supported. But here was the fundamental problem. What one operator supported, another operator didn't. Where the majority of operators here might have supported a patient, some people didn't, and that extended all the way out to here. And so when we're trying to develop a systematic way of applying a therapy, really identify the green patients, then we need to have a little bit more detail and a little bit more granularity on how to do this properly. And so the fundamental problem here that he recognized they had run into was that, say you have a patient like mine that I presented, or a 72-year-old with a non-STEMI and 2-vessel CABG who gets an Impella-supported PCI, gets 4 stents to 3 vessels, does great, the Impella is removed at the end of the case and they're home in 48 hours, or worse, you don't put the Impella in and then the patient crashes and tanks. Did you do the right thing? And this is that whole issue of the counterfactual, which is that you don't know what would have happened if you did the thing that you didn't do. So did you do the right thing by putting the Impella here? Say my case didn't go south, given that the anatomy wasn't so bad. Maybe putting the Impella on that individual or putting any hemodynamic support on that individual would have been the wrong thing to do. Did you prevent a near miss that you'll never know about? Or does the absence of a complication, does the fact that you got in and got out safely, even in that Ramus case, say we got in and we got out safely and I banged a stent up, didn't IVUS and got out, does the lack of a complication mean the correct choice was made? Maybe he had a bleed, but his life was saved. So you have to balance these things, and that becomes quite challenging, and that's why we need the granularity of data. So the idea is to look carefully at the best data we have and be both honest and prospective about the data, so retrospectively review and understand your own practice, and then be prospective about your next set of data, right? Take the data and take what you've learned from your experience and then apply it to your patients that are going to be considered for support forward. And that's what they did. And so they took in 2017, they took their algorithm and they prospectively applied it to their patients who may need support. And they found that 33 of them were not supported versus 39 who were supported. Ages were about consistent and ejection fractions were about consistent. And what they found was that there was no one factor that really jumped out that said, these individuals clearly need support versus these individuals clearly don't need support. And when they really parsed out the data and they looked at the individuals who did not get supported in the likely to support or likely to need support group versus those who did get supported, what they found was that the ages were similar, and the only things that really started to predict whether or not they were going to implant support, so not necessarily whether they did the right thing, but whether they were going to implant support, was the PHS saturation, okay, so a reflection of the hemodynamics and the cardiac output, the LV EDP, so the patient's overall filling pressures and volume status, and whether or not they were acute coronary syndromes. And that's not entirely surprising because this is an inherently less stable group. So what they did then was they simplified their algorithm and they made it all about the hemodynamics, whether or not the patient was congested and whether or not they had come in with an ACS. And now they're prospectively following these patients to try to understand whether or not what they've done is right. So let's look at the UK experience for a minute. Now, this is a fundamentally different system than here in the United States, where when you put in hemodynamic support or you do a case, doesn't matter what it is, there's remuneration that comes to you as an operator or into the environment as a hospital. That's different than in the United States or in Canada or the UK, where you have a managed healthcare system and you start with a pool of money at the early part of the year and you have to spend it wisely. And that's still different than the Indian subcontinent system, where it's in many places a patient pay type of environment where difficult care decisions have to be made. And so what the UK did was, over 4 centers, they took 234 Impella procedures, 5 of which were bailout and the rest of which were either high-risk PCI or cardiogenic shock. And they followed these patients up both at 30 days and out to 1 year. And their high-risk PCI population was interestingly similar to the one in the United States. The age was sort of 73.3, males were about 78% versus 70% here. And previous myocardial infarctions were present in about half of patients. But interestingly, this is where it comes down to how we suss out and apply randomized controlled data, and how sometimes those data are homogenized such that they may not be the optimal data for our own population. When you compare the UK Pella registry to the PROTECT2 data, you see that though ejection fractions were slightly higher, there was a huge segment of unprotected left main PCI in the UK Pella registry versus a not reported segment in PROTECT2. And importantly, the amount of atherectomy, the amount of calcium modification done was very, very high in comparison to PROTECT2, almost 3 times. And so this is clearly a sick and challenging population, and arguably more so than than the group in the PROTECT 2 trial, but whether they're more challenging or less, the point is that they're fundamentally different, and that difference reflects the local learning and local practice patterns. And so it's important for these individuals, as they have looked at their own data, to do what they're planning to do, which is move forward in a prospective fashion to be able to define a protocol through which they can understand how best to use hemodynamic support in high-risk PCI. So looking at US PELA or CVAD or Jamie's data from Washington and looking at the US PELA registry, I wonder what Indy PELA might look like, what a registry for India or what a protocol might look like. Well, that's what all of these people wondered a few months ago. And this was at the CHIP-CTO India meeting, where just prior to that, there was a conclave of operators across the country, some of whom are on the panel and with whom I'm honored to sit. My colleague, Dr. Tayal, who's sort of the overlord of all things axillary access, is on here as well. Dr. Seth, Dr. Trehan, Dr. Punamya, and many other excellent operators got together and we brainstormed. We said, well, here's the experience outside of India in the United States. Here's the experience in the UK. But what does our own environment look like? And is it as feasible to put hemodynamic support in the same groups of people? And using the various pieces of data that were available to us, so to understand where we need to go, we understand where we have been, we were able to define a prospective algorithm for the Indian subcontinent and surrounding areas. And this is what it looks like, where similarly a scoring system is put together, but I'll highlight to you some of the differences in that here, left ventricular ejection fraction has been specified with an LVF of less than 35% of 1 point and less than 25% of 2 points. There's a specific line for systolic blood pressure. And interestingly, for example, in the Washington algorithm, the LVEDP that was set as concerning was 20. Herein, it's 25. And there's specific mention of cardiac index of less than 2. But these operators, despite the Washington experience, have recognized the importance of support in high-risk atherectomy, or understand the potentials for trouble in large areas of myocardium at risk, so functionally single remaining conduit arteries, and then recognize the concerns associated with things like renal dysfunction or the surgical turndown patient, which is a hodgepodge of multiple factors that have been shown to increase the risk of in-hospital mortality by 6-fold. And then following implant, there is a basic weaning protocol that's also been suggested and defined based on their risk category. And so the important thing will be to take this protocol across institutions, apply it, be honest with the data, analyze it, and then be prospective going forward. And that's really what's happening now across the country, and we're all excited to see what the data of that effort will look like. So in conclusion, optimized use of mechanical circulatory support in high-risk PCI depends largely on patients and operators, but also environmental factors. How easily available is the device, what your local patient population is like, what their risks of bleeding are like, and what have you. And so we recognize that protocols may not be the same everywhere. And it's important then to be honest with our own data so that we can set up the best protocol for our patients that is most likely to have benefit. We set a structure in our own programs and we follow them, and we keep in mind, most importantly, that though hemodynamic support is an evidence-based excellent therapy that helps in a number of different clinical subsets, it is not a substitute for good evidence-based PCI that is incumbent upon all of us. Thanks very much. So with that, I'm going to move on forward to my next speaker, and we'll try to move into questions towards the end with the segment that we have for discussion, just in the interest of time. And so with that, it gives me pleasure to introduce Dr. Raj Tayal, who will take us forward with a discussion on managing complex PCIs using hemodynamic support, the fundamentals. Dr. Tayal.
Thank you. That was excellent, Sanjog, as always. It's a true pleasure. I'd like to echo your sentiments with regards to inviting and welcoming all of our colleagues and thanking them for taking the time to join us today, despite everything that's ongoing across the world. So we're going to talk a little bit about managing complex PCI by capitalizing on hemodynamic support today. So in the United States, at least, it's well known that there are several comorbidities associated with PCI in terms of complexities. So when you look at these can be teased out into different varieties of complicating factors, such as low ejection fraction, in-stent restenosis, chronic total occlusions, left main disease, multivessel disease, as Sanjog had pointed out earlier. The under-recognized thing, I think, an important thing to be cognizant of is that the overall percentage of these factors is relatively high, in that around 60% or so of these PCIs then fall into some categories being complex. So this forms the fundamental basis of the CHIP premises, wherein we need to focus not so much on treating the low-risk patients that are easier to treat, but focus more on appropriately treating patients that are at higher risk, that have the most to gain. It's well known that the degree of coronary calcification is a predictor of worsening outcomes, where you see patients with mild calcifications typically have lower rates of death, TLR or MACE. However, patients with significant calcifications have rates as high as 15% or so when undergoing intervention, as teased out from the Horizons AMI and ACUITY trials. So when you look at across the United States, there's around a 12 to 15% rate of severe calcification involving lesions that are being treated. However, the overall market penetrance of atherectomy remains at less than 5%. There's also a growing population of patients presenting with cardiogenic shock, as well as patients presenting with acute myocardial infarction in the setting of cardiogenic shock. And this number continues to increase from 2014 onward. So in more contemporary times, what we see is that if you take about a million patients that are undergoing PCI, you'll see that there's around 215,000 patients undergoing CABG in the United States. And of that, there's around 160,000 patients receiving that are presenting in cardiogenic shock. However, the overall rates of patients receiving some form of mechanical circulatory support remain relatively low, and about half of those patients are addressed appropriately. One thing that remains relatively well known, however under-recognized, is that angiography often underestimates the degree of calcification that we see when using additional imaging such as intravascular ultrasound or optical coherence tomography. So there are a number of devices that we can use adjunctively to treat calcium, such as orbital atherectomy, rotational atherectomy, laser atherectomy, scoring balloons, or shockwave lithotripsy. However, there is a strong predilection to avoid using some of these devices, as they complicate procedures and extend the duration, as well as add to cost. However, it's important to recognize that using these devices to modify vessels prior to stent placement allows for improvements in the minimal stent area, which are long-term predictors of overall stent outcomes. So when you look at what happens when you use a form of atherectomy in this study called the SPORT trial, you'll see that there is a larger acute and luminal gain when rotational atherectomy is utilized as alone to a transluminal angioplasty and stenting technique alone. And this results in higher technical success, procedural success, and clinical outcomes. Similarly, this can be seen in patients undergoing orbital atherectomy. However, again, it's important to recognize that the rates of MACE and TLR are elevated in the settings where these are not performed. So when you look at the overall rates of patients with severe calcification, you'll see that often all large-scale DES trials have excluded patients with severe calcification in the sense where we know that the outcomes are worse, as we've defined before. What you can see is that, again, calcium severity worsens outcomes, and this is clearly reproducible and demonstratable across the spectrum. So one of the things that becomes a primary concern when you're looking at patients undergoing atherectomy becomes slow flow or no reflow. You can see that this occurs in about 5% of patients. It's likely caused by obstruction of microvascular microparticles. And usually you'll see that in patients with heavy calcification and long lesions or bulky calcified stenosis, but there's also an increased prevalence of this in patients with lower ejection fractions. So typically what you want to do is approach these patients with these risk factors by slowly advancing devices using shorter runs and avoiding long runs with rotational atherectomy or significant decelerations Typically, we try to avoid burr times of greater than 5 minutes in these settings. Tortuosity also becomes somewhat of a challenge in these settings, but what we try to do is avoid wire bias and kind of move forward. If you're aiming for the outer curvature of the vessel, we try to spin while advancing to favor this. However, using glide assist, if you're using orbital atherectomy, passing the lesion will have a tendency to bring the device closer to the inner curvature. However, again, when we're looking at ejection fractions, you can see that there is a clear increase in MACE in patients with reduced ejection fractions undergoing significant atherectomy, in addition to increased all-cause death and target vascular revascularization. So one thing that we've seen, as Sanjog had pointed out earlier, is that there is a significant reduction in MACE in patients undergoing hemodynamic support when you're using Impella as compared to intra-aortic balloon pump, which has been demonstrated in the PROTECT 2 trial. It's also been shown in the PROTECT 3, where patients that were treated more aggressively with left main disease with higher forms of atherectomy, as well as in multiple vascular distributions, had significantly improved outcomes compared to those that did not receive support. Again, we've seen reductions in MACE as we've moved more towards the use of an Impella CP device in comparing PROTECT 3 to PROTECT 2 data, and all of these compared to intra-aortic balloon pumps, again, resulting in reductions in composite MACE out to 90 days. And a lot of that relates to hemodynamic stability throughout the entirety of the procedure, in addition to unloading the left ventricle. You can see the comparisons of ventricular unloading with the Impella 2.5 compared to intra-aortic balloon pumps. And we've all seen these pressure volume loops before. Again, comparing an Impella to an intra-aortic balloon pump, you see decreases in left ventricular pressure as well as decreases in left ventricular volume. So what that translates to overall, as Sanj had kind of demonstrated, is improvements in mean arterial pressure, cardiac output, power output, as well as reductions in pulmonary capillary wedge pressure. And so the goal of this is not only to achieve a better immediate patient outcome, but to result in improvements in ejection fraction, which are maintained post-procedurally as well. It's also been demonstrated that pre-procedural unloading has resulted in reductions in infarct size. This is now being tested in the form of DOOR unloading in acute myocardial infarctions involving the LAD. So with that, I'll present a case. So this is a 77-year-old female who had a TAVR in 2013, who was admitted with a non-ST segment myocardial infarction. She's known to have a prior PCI of the RCA and LAD, which was done in 2012. She's hypertensive, diabetic, has chronic kidney disease, and a reduced ejection fraction. And you can see her blood pressure is a little soft and her heart rate's slightly elevated, but nothing too significant. So here are her baseline angiographic images. You can see the valve prosthesis in place. She's got distal left main disease, as well as a high-grade stenosis of the mid-LAD right at the bifurcation. Here's another angiographic view of it. So after doing the diagnostic angiogram, the RCA was widely patent. What we did is we upsized the arteriotomy after placing one perclose and used the single axis technique after placing an Impella CP sheath in. We then put a 6 French guiding catheter beside the Impella, engaged the left main, and performed orbital atherectomy. You can see here we're slowly advancing the crown. And post-atherectomy, you can see a significant improvement. High-pressure balloon inflations. We then placed a 3.5 by 20 stent, proceeded with stenting of the left main while wiring the side branch. And there's our final angiographic result. So in follow-up, we used a total of 60 cc's of contrast. There was no change in her creatinine. At 1 month, she's now doing well. Her EF is now normalized. And this is part and premise of what we do and why we do it. That's all.
Great job. Thank you so much, Raj, for helping us granularize, if you will, the nature of patients that are really going to benefit from hemodynamic support and then the fundamental mechanisms behind it. Help me understand, sort of in your own practice, because you do a lot of difficult vascular access patients. How much does calcification in the peripheral vasculature, whether it's axillary or leg, affect your ability to use large bore devices, and what are the sort of various solutions that you've started to come up with in terms of an implant piece? I mean, we're all afraid of bleeding, right?
Of course. So, you know, if you look at bleeding linearly relates to mortality, obviously. So you have to weigh the risks with the benefits. When there's significant PAD, we are very comfortable and facile with moving to forms of alternative access. I will say that with the advent and inception of lithotripsy, it's been a relative game changer for us. It does facilitate a lot of large bore vascular access, not only in the common femorals, but throughout the iliacs. We've seen very, very low rates of dissection with very good procedural success rates of being able to remain, quote unquote, stay femoral. So that's probably been moved up to #1 in our access algorithm. I am a strong and very big proponent of using ultrasound to assess vascular access prior to proceeding.
And so once you've identified a particular access choice, is it your typical practice to use a single access approach for your PCIs, or do you still get secondary access, and if so, why?
So it depends. You know, if a patient comes in and they seem to be relatively hemodynamic stable, we are predominantly radial first. However, if the anatomy defines and we need to move forward with mechanical support, then typically we will obtain a secondary access. However, if it is a staged or planned high-risk PCI, then yes, we're typically femoral and single access.
I guess the point there is that early implant, if you're going to use, whether it's a balloon pump or an Impella or what have you, the switch from a prospective early implant stabilization and then PCI approach is data after data after data. I've supported this is better than the bailout approach because your patient's already taken the hit the first time around.
Absolutely.
And you know, and the single access approach has really been a game changer in that regard because it makes it so much quicker and it makes it a less worrisome event to have to get a second access while completely heparinized.
Right.
Great, thank you very much, Raj. I'm going to move forward then to my friend Rustam Dattov, who's in Brisbane, Australia. I can see that the lights are there. The daylight is down in his part of the world, as it is still down in mine. Rustam is going to take us through a complicated chip case over the next 10 or so minutes. Dr. Dattov. I think you're muted, my friend. We're going to have to get you to unmute yourself there.
Yeah, thank you, Sanjog and Raj. Great presentations. So I guess we now go through some cases. Out of all my cases, I think I will just show again the case I presented a few times where things went wrong and Impella was saving device. Let me see if you can see my slides. Can you see them?
Yes, we can see them just fine.
Excellent. Okay, so it's a case of an elderly man who essentially was assessed by our heart team, given he had severe aortic stenosis. So the teaching points here, you will see high-risk rotablation, use of several devices and few techniques. So he's 91. That was 2 years ago. The only thing in the past, he had mitral valve repair. And just a few months prior to this presentation, he had normal LV and was followed up by another cardiologist for moderate to severe AS. He had 3 months of crescent angina presented with non-STEMI. And on the Cath that you will see, there was a critical coronary artery disease. At this stage, his EF was 35. Global hyperkinesis, so everything was pointing to the fact that it's just low perfused hibernating myocardium rather than anything else like burnt out AS. He was seen by 2 senior surgeons. He was rejected, and after presentation on our heart meeting, he was approved for Impella. So you will appreciate here left main disease. There is significant LAD disease as well in the mid proximal and ostial circumflex. So this is a man with severe aortic stenosis and AF of 35%. Right coronary also has disease, but it's not really large, and we didn't plan anything for that. So as discussed, his quality of life is really bad. He is completely well with his brain, drives a car, and cannot walk with his angina. So this is access, crossing the valve, delivering Impella, CP. We were actually the first site with Professor Darren Walters to do this device 3 years ago in Australia. Delivery. I had a structural colic on this case scrapped with me in case if a device doesn't go through the very calcified valve, but you can see on the right slide that eventually goes, because otherwise the plan would be to do BAF, and we had separate access for that. So once the device is across the valve is not on our list anymore, at least for the duration of the case. Then I did a rotor of the left main LD with 1.5 burr, as you can see. That was straightforward. Then just I did a stent at that point, I think, to the LID. Yes. And then did rotor ablation of the circumflex. Ballooning of the circumflex. My plan was to just do a single stent in proximal LD and then left main to circumflex. In elderly man without just 2-stent technique. You can see perforation noted at the time of deployment of the positioning of the left main circumflex stent. So echo was requested at that point. Deployment of the stent, because we still have to do that, optimizing that. Echo at that point shows an effusion, but not too bad. So we have time to complete our work. So the question is where the bleeding is from. So it looks like most likely from the ostium of the circumflex. A few more views. And it's still going. So at that stage, I decided to complete with second stent from the ostium of left main to connect to the proximal LED stent, kind of reverse culotte. Optimize that. Bleeding continues. As you can see, it's almost like an intermediate ramus branch there. At that stage, by ballooning and pulling the balloon out and injecting, I was trying to identify where is the bleeding just to confirm. And only positioning the balloon at the ostium of the circumflex, the bleeding was stopped, controlled. Just to make sure, we did the same on suggestion of my colleague through LID, just to make sure, but here inflation in LID, the bleeding continues. It's clearly at the roof, at the ostium of the circumflex. Ballooning that for 5-10 minutes did not cause anything. He was stable despite that because of the Impella, making up to 3.5 liters at that time. So that was time already to do pericardiocentesis. And given that he had femoral vein, I created autotransfusion circuit. And the bleeding, as you can see, continues. On the left side, you can see it's almost the ramus there. About 500 mils, I think, was aspirated. So the choice here was of either graft master that we still had on the shelf, or PK papyrus. We don't have other. This is the deployment of PK papyrus. I think it was 40/20. And at that stage, I already had dual lumen catheter on the table. I had a Stata 20 wire and CP12 wire all ready to go. Because by doing that, LAD is occluded. And at that point, he started to become really sick, despite impeller. Started to vomit, blood pressure dropped. So you can see 2 dots of Crusade catheter, similar to twin pass that you have in the US. And this is a Stata 20. Just slicing through that, it has no resistance. And because LAD proximal had a turn there, I wasn't comfortable with that. It was going through papyrus very easily, but a couple times I thought it went through LAD as well. So at some point, I changed it to CP12. And I had to put double curve just to follow that LAD. As soon as CP12 was there, after trapping, as you can see, trapping balloon there, Corsair went and replaced Crusade. Then through Corsair, workhorse wire was introduced, 1.5 balloon, 2.0 balloon, and 3.0 balloon to fenestrate that papyrus towards LAD. And the moment I removed Corsair and there was only workhorse wire in LAD before 1.5 balloon, patient hemodynamics started to improve significantly with that tiny flow into the LAD. As you remember, his right coronary is not a big artery. So this is injection after fenestration with 3.0 balloon of the ostial LAD through papyrus. I had to just optimize papyrus stent. It's very important, regardless of the geography of the deployment of that stent. You just always have to optimize it because it's more softer than the graft master, especially the ages you have to do. So there was only minimal extravasation after that. So this is summary of the case before, after, and in the middle. As you can see, there is almost a iatrogenic artery. So the case took 8 hours. 4 hours I dealt with complication. Was high radiation case, 7 grays, 180 mils of contrast. Next day, impel was removed. 5 weeks later, his LV was 55, but he still had CVES. 5 months later, he came back for a pre-TAVR angiogram. Everything was fine. And had, so that was in April 18. 7 months later, he had, a few months later, 5 months later, he had this TAVR. This is at 1 year. And he is now 2 years. He's doing well, still driving a car. He also had mitral clips in since then. So these few things we can do in Australia. This case was published. It was one of the top 10% downloaded last year in CCI. If we didn't have impeller, he probably wouldn't be on this picture, most likely, because things went very fast downwards as a spiral. This is a good discussion. People may say, could you do just ostial circumflex? This is very difficult. You can miss it, and how are you going to optimize that? I thought in that case, it would be important just to do it across and fenestrate. Why I was comfortable? Because about 3-4 months prior to that, I read a paper, case report by Gerhard Werner, one of the top CT operators in Germany, who had something similar, where the guy dissected left main, and there was a perforation when they were doing right coronary. So attending forums like this, reading case reports is, I guess, is very important. If you one time, 5-10 years later, will remember something that you saw today, and that will help you to save the case, I think that's the whole benefit of this 3 days conference that is arranged. Thank you.
Thank you, Rustam. That is a phenomenal case. I've seen you present that one before, and I always enjoy watching it live because you know, despite being such a tremendously difficult scenario to manage, your voice is always so calm and controlled.
This was actually in my second year out of fellowship. But again, knowing the equipment that you have in the lab, seeing these cases somewhere, someone else's mistakes, it just helps you in the future. If I did this report, I wouldn't do that. For example, I wouldn't stent across. I would know that you can finish straight papyrus. So that's why it's very important. Every case presented over the next 3 days, I guess it's a good teaching point that may help one day.
I think that's a very important point. Each of these things is really a case study in itself. Let me reach out to some of my panel members. The question I have actually is how you mentioned that you had a structural support or structural interventionalist scrub with you during this case. I mean, let's start with Dr. Rao there, Dr. Ravinder Rao. As a director of structural heart disease, do you often scrub on these types of cases with your coronary operators?
Dr. Kalra, I think Dr. Rao is in a case at this point of time.
Okay. I'll ask Dr. Is Dr. Kumar there? Dr. Vivek Kumar?
No.
We have him as well. He's also not on the line. Okay. I do see my friend Dr. Vishal Rastogi. Maybe I'll reach out to him and ask him to comment.
So this was tremendous case, Sanjog, and it was wonderful seeing this. Of course, the biggest worry that the coronary operator will have is whether Impella is going to go through that calcified aortic valve or not, and that's the reason that Rustam had his colleague with him in the case. I would think that it is very vital that we have structural preparation also. In India, it's, Ravinder also does coronary as well as structural. Our group also does both the cases together, so we can handle these kind of situations in one go if the need be. But then yes, required to handle this, and this is a tremendous case for learning both how to handle these kind of cases and manage complications, and it's very well done. Great.
What else I can suggest in this case, what I learned retrospectively, is if there is a complication like that, you have a bifurcation, doesn't matter, big diagonal, a big OM branch, and you have to stent across, deploy ostial stent into that branch, short stent, just deploy it quickly. So that way, when you deploy the papyrus or similar stent, I guess you can do it in GraftMaster, then you have a target, because otherwise poking those stiff tapered wires by itself can cause mischief.
I was just going to mention that, in that if you don't, I had this asked to me a few days ago actually by a colleague of mine that read your case and said, do you always stent the main artery if this is a highly angulated vessel or there's a worry of perforation? And I'm impressed that you were able to do the work that you did for a period of time without getting a tap done. I think my personal practice would have probably been to put a pericardial drain in first, put a balloon up in the circumflex because you had hemodynamic support, occlude the bleed for a few minutes. If that was still bleeding, put the balloon back up and put a drain in, set up the auto transfusion loop, and then worry about restenting. But I see that you worked quickly and you were able to get this done.
I think over a period of 20-25 minutes, I had about 3 echoes, and on the third echo, I said, "Okay, this is the time to do it."
It's time. Yeah. I mean, you know, it's easier when there's a little bit of fluid there for sure. I think the point that I was going to make is that if you don't have, a lot of times when you're doing these types of procedures, you have wires down both arteries as well, right? So we have had experiences where we've put papyruses with a jailed wire behind us, recognizing that the stent is on the inside and the smooth covering layer is on the outside. If it's an 014 hydrophilic wire, you can actually get that wire out from behind the papyrus as long as you have a safety wire down the vessel with the papyrus in it and a balloon on that safety wire, so that when you pull the wire out, or if you have to take a smaller balloon behind to dig it out, that you have another balloon already in place that can just push it back towards the wall. That's fantastic. I'm going to move on again in the setting of time, but we're going to have a chunk of time for discussion of all of these cases where we'll reach out to the other members of the panel. The next case I'd like to invite up is Dr. Mathur, Dr. Atul Mathur, who's the Director-in-Chief of the Cath Lab at Fortis Escorts Heart Institute, who will present us his case entitled Rota-Assisted PCI with Prophylactic Hemodynamic Support. Dr. Mathur.
Yeah. Hi, everybody. So, are you able to see my?
We can see you.
Not yet. Okay, I'll do the share again. It was great seeing the last few presentations. So much of learning in those presentations.
That's great. We see your screen now.
Yeah, so I'm going to maximize my presentation. So this is, of course, we were lucky we didn't have a complication in this case. And this was kind of a teamwork. Dr. Vishal Rastogi, who was here with us, he was part of the procedure, and Dr. Praveer Agarwal, one of my colleagues. So this is a story about a 82-year-old, very frail lady. She already had multiple comorbidities. She was a diabetic, hypertensive, chronic kidney disease on maintenance hemodialysis at least thrice a week. She had several procedures to her grafts, which fistula grafts, which ultimately gave way. So she was on a permacath through her subclavian on the right side. So in 1999, that's nearly 20 years back, she was diagnosed with TVD and had grafts, Lima to the LAD, Rima to the RCA, and a vein graft to the OM. And she did well on her coronaries for a long period of time, till about 3 years back. She had developed symptoms during her dialysis. She used to develop angina. And it was found that on an angiogram that her Rima had occluded, and a vein graft to the circumflex territory had also occluded. The inferior wall at that time was scarred. The Lima was perfusing the LAD. The mid portion, distally beyond this, there was diffuse disease. So she was subjected to a stenting to the circumflex, proximal circumflex. And so notable things at this time were that she had a lot of calcium, and she had a lot of fibrosis in these vessels. So only a proximal circumflex stent had been placed at that time. And beyond that, there was a bend which did not allow the cutting balloons or other devices to pass through. So she was left at that and her symptoms settled down, and she remained good for at least another 1 year. And subsequently, she again had recurrence of angina, not as severe as earlier. And she had undergone another angiogram at that time, 1 year later, that's in 2018. So the circumflex stent has developed in-stent restenosis. There was, the ejection fraction was 30%. We know the RCA is infarcted. Then we also know the LAD beyond the Lima distally is diffusely diseased. And so she was managed on optimized medical therapy, and she did well for another 6-7 months. Subsequently, now in the year of 2019, she developed recurrent episodes of rest angina, and this time with significant ECG changes. And each time she would go into failure also. She was not able to tolerate her hemodialysis, would get hypotensive with a short run of dialysis. So then ultimately we had to give a thought, and by that time we had this new hemodynamic support available in our country. So the echo at this time was revealing 30% ejection fraction, inferior wall was scarred, and 2-3 sequential echoes showed variable, moderate, and severe mitral regurgitation. So probably it was ischemic. So she was again now taken for an angiogram with a plan that if we have to proceed with any intervention, because last time we had left her because it was a very high risk situation and her vascular accesses were not good. So we didn't consider an IBP during that procedure. So this is the right coronary artery is diffusely diseased and infarcted. And the shot from the Lima shows the Lima graft is patent, it's running well, a lot of septals are filling from there. Distal LAD has got diffuse disease. And finally here, if you look at this, the LAD to proximal LAD has a moderate 40 to 50% plaque, and which is leading to a large, moderately large diagonal branch. So the disease is moderate in this vessel. So the caudal view shows you that there is so much of dense calcium in the left main, around the left main, as well as in the circumflex. and fibrotic bends, which you will feel more when you get into these arteries. The LED is flowing well, reasonably, and filling up the diagonal. We have a large territory coming out of this circumflex to 3 big branches. The distal circumflex is a co-dominant system, but the inferior wall was infarcted. So if you look at the caudal view, the heliocaudal, so there is barely you can see a stent in the proximal circumflex. There's an ostial circ stenosis. There's a tight stenosis just beyond the stent. There is a severe bend which is fibrotic, and then there is moderate plaque over here in this circumflex. So our you can see this permacath for the dialysis. So here what we have in this lady is that this is definitely high risk PCI, which was avoided at least 7-8 months back, but now the symptoms are so severe. She is got several comorbidities. She's 80 years plus, very frail, diabetic, on hemodialysis. Ejection fraction is below 30%, ischemic mitral regurgitation. And we are intending to treat a very large area of myocardium, which is viable. Actually, this circumflex is supplying at least 70% of the viable myocardium. So we definitely warrant hemodynamic support during this procedure. And we intended to use a rotational atherectomy, keeping in mind the ISR, the fibrotic bends, and the calcium present. So the concern was during rotational atherectomy, there would be a risk of slow flow and which may destabilize the patient. So that's the reason which prompted us to use the impeller. So we took an access from the contralateral groin. At that time, the same sheath, single primary procedures were not the norm. So we had 2 accesses, and then the impeller went in easily. We crossed it across the aortic valve. And the patient was quite comfortable, stable after this. Now here we chose 7 French JL guiding catheter, lightly engaged because we didn't want to go deep into a diseased left main. Our intention was not to touch the left main because it is a 40% plaque maximum, and there's chunks of calcium on the left main, and we did not intend to treat that. And we, if we put our stent back to the left main, then we were worried that we might unnecessarily interfere with the proximal and ostial left anterior descending, which is supplying a reasonable myocardium over there. So we took 1.5 rotabar. And again, there was a challenge that there would be an acute bend. So it is an acute angulation. And we had to make sure that we did not go very aggressively with the burr. So there was a careful advancement of the burr. A temporary wire was placed in this patient because then it's a large myocardium and we did not want to risk any bradycardic episodes. So gentle pecking motions with the rotablation. We took a little time until ultimately the ostial region was crossed. So we were careful that not much force was used. So after 5-6 pecking movements, this rotablation of the proximal portion was completed. Now, the distal fibrotic bend, which was not allowing any cutting balloon or any cutting balloon to pass, as well as an NC balloon, would not open up completely. So the burr went through very easily across that. Several passes were made. And we thought we had prepared the bed decently. We went for some balloon dilatations following this sequentially. And we were able to open up our balloons comfortably. So the final balloon dilatation was done with a 3O balloon, non-compliant balloons. And we had reasonable assurance that we have created a good bed to implant a stent. So a long stent was taken and sizing was done. And the stent placement, we were very careful that we would remain at the ostium of the circumflex. Several checks were done. We were very keen to preserve the LED ostium, and we had no intentions, and we did not do any balloon dilatations in the region of the left main. So the stent was deployed, and this was the shot after the stent deployment. So it looks reasonably expanded, but we still had to do some work because there was so much of fibrosis and calcium involved. So ultimately, after all NC dilatations, we took the OPN balloon and went up to 35 atmospheres to ensure, because this is the most critical region which is restenosed, and these have a tendency of coming back again and again. And in this lady, we really did not want a recurrence at our hands at this point. So finally, we went to high pressures of 35, and this was the result with which we left this lady. So reasonably good flow. We were lucky with the distal circumflex artery, which is flowing very well. The LAD has not taken any plaque, so it is continuing to flow and supplying the diagonal. And the distal two branches are flowing very well. So she tolerated the procedure well. The impeller was removed post-procedure on the table itself, and the subsequent echoes done a day or later showed mitral regurgitation had regressed. 3 months later, the ejection fraction had climbed up to 45%. So that was a significant improvement, and this area was causing both mitral regurgitation as well as ischemic dysfunction of the heart. Now, she came back. She's been doing her hemodialysis in a hospital regularly. In fact, now it has been nearly 14 months since this procedure was done. And in fact, during this period, in the last 5 months back, I think she underwent an ERCP procedure also very comfortably. She's tolerating her hemodialysis and does not get any anginal episodes. So we feel that we were justified in electively using an impeller in this patient. Although whatever studies have been done with rotablation, impeller has not shown a major significant advantage, and we'll probably take these points for discussion. But definitely, if you have an impeller, you are able to do a more complete and a thorough job with your procedures because you are assured about hemodynamic support. And that is what in a lot of other centers, of course, in a less than 35% with a large area of myocardium, you definitely choose, you're inclined to use impeller before the procedure. And it can come off if the patient has stayed well during the procedure and the angioplasty has gone well. You can take it out during your cath lab itself. There are some situations where even with a normal ejection fraction, people do consider an impeller if you're doing a lot of vessels. I think Vishal is going to show another very complex procedure on that. Thank you very much.
Excellent presentation, excellent case, Dr. Mathur. I really enjoyed watching the specifics of how you managed to get such a nice result in the circumflex. I saw that you used the OPN balloon. Did you consider using intravascular imaging to define the size of the minimal stent area there, or did you use it? And what are your targets there?
At that point of time, in our labs, we had an option of doing an OCT. The IVUS machine was giving us a little trouble, so we had an OCT at our hand. And so this was a choice, and why we used an OPN was that we wanted an adequate stent deployment. And given a patient with such bad kidney renal failure and all those things, we didn't want to give her too much of contrast to harm her in any other manner. Otherwise, an OCT would have been very good adjunct to make sure that the stent deployment has been adequate. So that was our constraint, and that's the reason we went with the OCT, the OPN balloon.
Yeah, I understand. I think that's a very thoughtful approach. The challenge is obviously with OCT is the use of contrast. There's some newer data coming out, isn't there, with Ziad Ali and his group at Columbia University, where they're starting to demonstrate OCT using either high pressure saline, which tends to work quite well in the right coronary artery, or selective vessel saline OCT in the left coronary system, recognizing that the refractive index of saline is a little different than that of contrast. And so the nature of the images are slightly different. You need to systematically correct them. And there's going to be more coming on that front. You mentioned that calcium and the data around calcium and hemodynamic support is unclear.
I was looking at the PROTECT 2 trial and rotational atherectomy. There were not too many people in that category. So those people who underwent rotational atherectomy, with or without impeller, probably there was not much they could show a difference in those. So whether patients undergoing rotational atherectomy with an impeller are benefited or not is we need some more evidence. But here, since our case was involved rotational atherectomy, and a lot of people are using atherectomy in chip cases, so a randomized data is yet to be available. That's it. But I think because if you have an impeller in place, then you have sufficient time to do good drilling and spend time on multiple vessels. So that is a logical advantage I think one would enjoy.
Yeah, I think you brought up a good point, which is that, you know, I mean, randomized data we look at as the sort of gold standard, if you will. But again, we have to recognize that these are very controlled environments, and real world data sets are sometimes quite informative, like the UK PELA data set, or perhaps the one that, you know, is being developed in India with the protocol that's being applied there. But from a randomized perspective, there is more randomized data coming with the PROTECT 4 trial, which is a randomized control trial that will compare those who are undergoing high-risk PCI who are on hemodynamic support versus off hemodynamic support. And certainly looking at the nature of the disease sets that are coming to the cath labs today, we're likely to see more calcified lesions being treated. That's why you see, I mean, almost a third of patients in UK PELA who had a rotational atherectomy. And I guess the important thing to recognize there is it's very hard to prove that counterfactual, right? If you didn't put the hemodynamic support in and did get slow flow in this individual with, you know, poor underlying ventricular
we were in
function,
trouble in this case.
Then
that's why we
you kick yourself,
postponed it once.
Afterwards, right? So that's why we made the point earlier about how important it is to take a systematic approach to defining the types of patients that you're likely to need support on. Use it, be honest with your data, and then refine your approach so that you can really zero in on that population that's likely to benefit. Raj, I have a question for you, sort of with these types of cases. This patient had significant mitral regurgitation and it was ischemic. How does MR enter into your risk assessment for patients? And how does it differ if it's ischemic MR versus secondary MR with a big left ventricular and diastolic dimension? Do you use more support, less support? Does it matter?
So, I mean, that's a great question. And what we've seen is that those patients with ischemic MR,
does it matter?
They tend to decompensate much quicker and respond to things a lot differently than a patient without. Meaning, if there's a tipping point, they tend to fall over that edge much, much quicker unless the ventricle is unloaded to some degree. And of course, that relates to the degree of intervention, the coronary distributions. You know, I do think that what you see is in vessels that were shown that were heavily calcified, kind of the point of what I presented earlier. When you have that much calcification, you have that degree of atherectomy being performed, having some form of left ventricular unloading and support does facilitate a reduction in MACE and does kind of reduce the chances of having slow flow, no reflow. And again, you know, these have been shown in a variety of different ways, but, you know, ischemic MR is something that I think is often underappreciated as a risk factor.
And with sort of the advent of things like MitraClips and other structural heart disease interventions, do you feel like the combination of chip, coronary, and structural heart disease specialists in the same cases is more and more likely to come up, or do you feel like they should be best done as a separate events? Do you think there might be a role for hemodynamic support in that environment?
I do. I think that you do see a clear intersection of multiple specialities and people kind of becoming versed in multiple directions. We don't typically do everything in the same setting and like to space things out. There have been a few flail leaflets and things like that we have done with hemodynamic support. But again, usually we attempt to resolve the acute ischemic issue prior to proceeding with the structural intervention.
Mm-hmm. And I mean, thinking back to your case, Rustam, where you had a structural heart disease specialist that was in the lab. I mean, what's your approach if the device doesn't go across? How do you manage that sort of scenario?
It hasn't happened so far like this, but that was the reason I had structural colic to do balloon valvuloplasty immediately. We had second arterial access for that 7th range. Obviously, if you have impeller program, you must have a heart team in your hospital where you have excellent surgeons, couple of them. You have top PCI operators, you have heart failure specialists, and one good imaging cardiologist in echo to do a case like this. I mean, this case that was presented just now, you can see the MR was almost completely gone. Mm-hmm. And if this rotor was done without impeller, again, there is no much reserve there. This patient is on the edge. I had very similar patient, 73 years old last week, where right was CTO, LAD was moderate, and circumflex was diffusely disease calcified. I did IVUS of that LAD, again, not enough for surgery. Put IVUS into circumflex, patient crushed. I had to retrieve it immediately, put to CCU. Eventually went well, but I couldn't do anything beyond just retrieving IVUS. That's how they're on the edge. 4-on-4 ischemic MR.
Yeah, I think that's a great point, right? And the reality is that we're still trying to. I mean, we only have so much clinical assessment room at our disposal, and that's why I think it's very important to move towards hemodynamics as part of the assessment in these types of patients. You know, we don't put people on vasopressors without arterial lines when they're at significant doses. It doesn't make a whole lot of sense to put people on hemodynamic support devices without being able to monitor the hemodynamics. I wager in this individual of yours who had high MR, he probably would have had very high wedge pressures, and you would have seen that he was on the edge. I don't know if you ended up doing hemodynamics in that situation, but that's the one of the important learning points, I think, of this new era of work that we in the Cath Lab are starting to manage is hemodynamics and failing hearts.
But on the same note, Sanjog, as you said, if it is secondary MR, long-standing 4-on-4, potentially you could do this rota. You know, I've done cases like this where yes, LV is dilated, but it's been there, they're well compensated, they can tolerate this.
But in these types of individuals, then you're going to see lower pressures, right? You'll see lower filling pressures because of the accommodation that you have, and that's really the point, right? Is you just have to get the information to tailor your therapy to the individual that you're treating. Great. With that, we'll move on to Dr. Jaspal Arneja, who is the director of the Arneja Heart and Multi-Speciality Hospital in Nagpur, who will be presenting his case entitled "My Experience with High-Risk Protected PCI." Dr. Arneja.
Evening.
Welcome.
I just get my.
We can see you very well.
Okay, great.
Just while our Dr. Arneja gets his, are your slides ready, sir?
Yeah, can you see my slides?
Great. No, we see you. We don't see your slides.
Just a second.
Should be a button at the top there that can switch between the camera and the screen. Excellent. We have your slides up.
Great. So it's a pleasure, to share my case with you with this August gathering here. So, patient was an 86-year-old male, fairly active male, who presented with an ACS syncope. He was climbing up the stairs and he felt some chest discomfort and stopped a little, continued, and maybe after a minute, continued walking up. And as he reached the last stair, he just collapsed. And from there, within a few minutes, he was brought to us. And when he came to us, he was quite all right, hemodynamically stable. The ECG, showed no very significant changes. His serial enzymes showed that the troponin was elevated. So he had non-STEMI with syncope, and echo was also interesting. He had about moderate LV dysfunction, 40% EF, and he had associated moderate aortic stenosis. Now we made sure that we are not underestimating his aortic stenosis, which could also present as syncope in this patient, but his valve area was more than 1.4 even with continuity equation. So we were dealing with elderly male normotensive with an ACS with syncope, and this was his angiogram. RCA is quite calcified, and but having I would say moderate disease. There's no severe disease in the RCA, but moderate calcified disease in the mid RCA. And here, as you see, the LED looks quite all right. There's some, again, mild to moderate disease in the circumflex. The left main here looks reasonable, but when you look at the cranial view, you can see here that it's a very tight left main here, right from the ostium, up to the just beyond the mid segment of the left main. There's a lot of calcium that you can see in this left main and in the LED and at the ostium as well. So, as you can appreciate this, so it's a critical left main with some calcium. So, obviously medical management was not an option. Now we had a choice between PCI and bypass surgery. Now, if this patient goes for surgery, 86-year-old guy, moderate aortic stenosis, at this he would also possibly require aortic valve replacement with a CABG. So, the choice was for a PCI by the patient also. And the next question was a PCI. What do we do? Do we do a targeted PCI, just tackle the left main, which seems to be the culprit, or try to do more complete revascularization? That was number one. Number two, whether he needs protection, a protected PCI. Now, as we have discussed, so this patient had comorbidities in the form of advanced age. He had a non-STEMI. He had real complex anatomy. There was a left main supplying the entire left myocardium, and there was a lot of calcium. As we have been discussing in the last few cases, calcium is a major sort of risk factor when we are trying to deal with patients like this, who may need a rotablation or some other form of plaque modification. So protection in these patients with large myocardium, a lot of calcium, does make sense. So, you can do a much better job, a more complete job in these subset of patients. So we thought that we are possibly just going to take care of the LED, the ostium of the LED to the mid segment. There's no need to go beyond the bifurcation of the left main because the LED and circumflex had only mild to moderate disease. So we wanted to just revascularize him by tackling the left main. Second was the calcium. He definitely needed some sort of plaque modification. So here the choice would have been either a rotablation or use some high pressure balloon. It's a EB guide, and which was positioned right at the ostium of the left main, the ostia, not going in, and we used a support wire, an extra support wire, and then we, this is a we thought we'll see whether a NC balloon goes in. We will take a feel of the lesion, that the calcium there, and fortunately the NC balloon, this is a 2.25 NC balloon across the lesion, which went in very easily, and we were able to open it, and it seemed to be opening it well. This is over a Grand Slam wire. Now that our NC balloon had gone reasonably easily, we thought we'll try to make it simple. We took an OP and NC high balloon, and we thought we'll be able to possibly open up the lesion, the calcium, modify the calcium with an open NC balloon at high pressure. Two things that we need to remember should avoid a polymer sleeve wire as far as possible. Preferably use an extra support wire like a Grand Slam or All-Star or a CM glue extra support. And when you're pre-dilating at high pressures, possibly a little undersizing would be desirable. And after a pressure of 20, it's good to go up gradually. So this was our OPN NC balloon. A 310 OPN NC went up to about 35-40 atmospheric pressures. Seemed to have opened up, very well. You can't see the vase there. So the ostium, the left main seems to be taken care of well with this OPN balloon now. And the, angiographically also it looks quite good. Now, having done this, we thought, we could use some IVUS or OCT, but we thought we've got a good result angiographically. So, we put in a 4/9 stent from the ostium into the body of the left main and deployed it, and which seemed to be a reasonably good result here. Post-dilated with a 4/6 NC balloon, and it looks wide open the ostium up to the mid portion of the left main. So, and since he was hemodynamically stable, he tolerated the procedure very well. The impella was removed on table, and as we discussed, once we have done the case, whether putting an impella was required or not, all these questions always come up. But obviously, when we are dealing with left main in an elderly patient, a complex lesion, heavily calcified lesion, which could possibly need a rotor plaque modification, I think having hemodynamic support, especially when the patient wants it to be a very safe procedure, it really gives us more time to do a more optimal procedure, a lot of operator comfort. And as we discussed, when we're dealing with calcium, we know we might take more time, we might need, some plaque modification, and hemodynamic support, if available, is always good.
Very good. Thank you very much. Thank you very much, Dr. Anuja. That was an excellent case as well. Lots of calcium that we're seeing, and we see this recurrent theme come up of it's hard to tell whether or not we've made a difference if everything goes well and the patient does well, which is ultimately our goal. It's really an interesting cognitive dissonance. I guess that it brings us to the data and our interpretation of the data around the bailout implant versus the upfront considered implant. So, Dr. Rastogi, can you give me your thoughts on those data and what you think about sort of bailout hemodynamic support versus upfront hemodynamic support in a case like this?
So I would agree that this dilemma always comes whether we needed the support or not. And Dr. Anuja said that it gives a lot of operator comfort, and if the patient wants it very safe, then you're better off using the device. But I would think that everything comes with its own set of complications also. And if you have one groin complication, or if you have excess bleeding, probably that will offset all the benefit that you get out of the device. So you have to be very balanced in deciding which patient would need it and which patient won't need it. Though I'm not saying that this case did not need it, but what I'm saying is that there are areas where you need to be careful that it may be harmful as well. However, it is said for most of the things, like, if you need rotablation, if you think that you may need rotablation, it is better to use it upfront rather than, using it as a bailout strategy. So it's true for this technique also, this device also, and it has been shown in multiple studies as well as anecdotal reports also that if you use the device upfront and you avoid all the damage, if we don't have the single access approach, then puncturing the contralateral artery with such a large bore access where you're not you're in a hurry, the patient is crashing on you, and then you take you're inviting more trouble rather than so chances of groin complications and other complications are going to be much higher. So I would think that's better to implant the device upfront if you think that you're going to need the device.
Yeah, I mean, I think you answered your own query quite well, and that you laid out the various potential complications associated with a crash implant, and that's really what we see in the data now as you look at the most contemporary or the most recent analysis of the post-marketing PROTECT 3 study, where the mortality associated with bailout is 49%. It's dramatically lower with an upfront implant. Now, again, your point's well taken in that one has to be balanced in their approach, particularly in an environment where it's a patient pay environment, and the idea around these types of procedures is the expectation of a guaranteed outcome, and that can really be quite challenging. But ultimately, I think as a physician, and I'm sure you will all agree, as will all of the people in our audience, we want to do a safe procedure whether the patient wants it or not, right? The idea is to have the safest and most efficacious procedure as possible. So, Dr. Aneja, I wanted to ask you explanted the device on the table after sort of multiple prolonged inflations in the left main and these kinds of things, and you had said so is because your hemodynamics were good, your blood pressure was good. How do you wean? What's your decision-making algorithm on deciding whether or not you should take the device out on the table or whether they need to go up to the ICU?
Basically, if everything is fine, the blood pressure, the overall hemodynamics, patient is comfortable, no angina, the procedure is all well done, the hemodynamics look good, and if you have some other, if it's really sick, you have a PA catheters or other things, he's not on any inotropes. So I think with everything favoring a good hemodynamics, like this patient was an elective, he was always stable. This was a protected PCI in a reasonably stable patient. When he came to the lab, he was hemodynamically stable. So in this patient, I think after the procedure, the decision was very clear cut. That it's better to get it out as early as possible. As we discussed, if needed, obviously you take it to the ICU. But in this patient, when he was comfortable, no angina, procedure well done, no inotropes, blood pressure good, I think getting explanting on the table is always a better idea.
Okay, and sort of a slightly different approach from across the pond. Raj, can you give me your approach to weaning? How do you decide if people need to take the device out on the table versus keep it in the ICU? I mean, we all know that sometimes the blood pressure lies, right? Because of vascular tone changes and intrinsic management changes. Dr. Mathur has a comment as well, so I'll ask him next.
No, please, go ahead, Dr. Mathur.
Dr. Mathur.
No, I can take it after you. It's much.
So, I mean, it's always a challenging question, and it's a trade-off, right? There are inherent risks to leaving the device in place, and I think sometimes some of us are pushed by the fear of having a bleeding complication or late bleeding or the inability to efficiently manage the device when it's not directly in our sight, whether it be related to the institution, the experience. And so I think it becomes more of a team and a concerted effort. And again, a lot of times in the setting of not having a PA catheter, it's not just about the blood pressure. More recently with the Impella Connect and some of the other advancements that we have here in the United States, you can actually look at the weaning pressures and things like that as you slowly tune the device down and come off of support, so to speak, in terms of getting real-time EDP measurements and things like that. Those things are phenomenal to have. However, I would say that what we've learned is we've done a number of cases where you do a beautiful complex procedure, multi-vessel revasc, patient goes up to the floor, you take the device out in the lab, and then has a poor outcome overnight. And I think there is a degree of stunning that occurs when you do complex revascularization involving multiple vascular distributions. So in my own practice, we've kind of been on a pendulum where initially it was do the PCI, take the device out, and then see what happens. And now we've gradually moved more towards having a PA catheter, even for stable, high risk, outpatients, so that we can make complete hemodynamic assessments prior to determining when to remove the device.
Yeah, those comments are very well taken. I think that there really comes down to being able to manage the hemodynamics, whether you're on support or off support, because ultimately you're going to cause hemodynamic perturbation by putting up balloons in critical arteries when EFs are down. Dr. Mathur, what was your comment?
So I just wanted to make a comment on the Protect 3 data, which we have mentioned. So don't you think that those patients who needed a bailout support, they are probably a little sicker group because they've all, for various reasons, for criticality of the lesion or the patient's situation, they have crashed and they needed an bailout. Compared to elective group where some of them may have benefited, but some may not have benefited. So isn't it prudent to develop some kind of a scoring system where you can really score and see that you can optimally utilize the impeller? So somewhere in between, rather than using in all the patients where you think you are not, or you're not confident. So
yeah, I think
scores like that, right?
I understand your point, and I think it's a valid point, and that's I think what a lot of us have mentioned in various comments. Dr. Datta Rustam mentioned a few minutes ago that these patients are on the edge, right? And so they may appear quite stable to you. And the idea is to be able to perform the best PCI you can and recognize that you don't know if a complication is going to happen. And so if nothing happens, nothing bad happens, then was the device necessary or not? That's that counterfactual. And that's a very challenging thing to prove or not prove. But the last point you make is a very important one, which is, do we have data? Do we need more data to be able to, in our own local environment, apply a rational approach to device and resource utilization? And I think that's what the operators in India are now moving towards, as they've put together the scoring system that I had presented at the beginning of this session, where there's an honest effort to try to identify the people that are going to benefit most, recognizing though that the only data we have, which is a reasonably large data set now, it's almost 1,000 patients, suggests that the sooner you, the more often you end up on a bailout, whether that's cardiogenic shock or high risk PCI, uniformly, you end up taking the first shock hit because your patient becomes unstable, and those individuals seem to have been doing worse. More data, I think is going to light the road in that regard. Just before we move on to Dr. Rastogi's last presentation, I understand that Dr. Chandra and Dr. Chauhan will not be able to join us because they are in a case. There was a question from the audience that said, is it okay to use an Impella with a prosthetic aortic valve? So I'll kick that off to Dr. Tayal, who does a lot of TAVR.
No, I would not. Bioprosthetics, that's really not an issue. However, mechanical valves are a contraindication, pretty much absolutely. In settings like that, if support's needed, I would consider ECMO. You can always consider a tandem heart if it's available, or even an IABP if that's enough support to get the patient through that situation.
That's an important point, right? So not only would it be contraindicated in prosthetic valves, but it's important to recognize the host of therapeutic options we have at our disposal. It's really about the patient. It's not about the device. It's about the patient, not the procedure. And hemodynamic support across high-risk PCI is a skill set, much less a particular procedure or a particular device. And so it's our responsibility to be able to assess the patient and tailor our potential therapies to what our patients need. With that, Dr. Rastogi, who is the Additional Director of Interventional Cardiology at Fortis Escorts in New Delhi, I will ask you to bring us your case and help us wrap up this session.
I think it was wonderful discussion so far. Can you guys see my slides?
Yes, we can. We can see your slides.
Let me just minimize this. All right. So from this, these elderly patients, let me bring you, shift you focus to the classical population that we see in India, which is very young patients who have I can't forward. How can I move? Okay, so this is a young male who's 55-year-old diabetic. He had atrial myocardial infarction 2-3 months back before he presented to us, and he was thrombolized. The patient continued to have symptoms of heart failure because of the poor ejection fraction. His echo showed a multi-segment wall motion abnormality with ejection fraction of 25 to 30%. He also had a mild mitral regurgitation. He was admitted to another hospital. He was sick and he was in the ICU. He required inotropic support and IV diuretics. After stabilization, those guys did his coronary angiography, which showed a bad triple vessel disease. So this is very common in our population, in which patients are younger. They have bad coronary artery disease, which most of us will think that is not amenable to revascularization. So that's what they did, and it was a reasonably good center. It's not as if it's a very, very peripheral center. So they inserted ICD and advised medical management because they thought that this coronary artery disease is not amenable to revascularization. So these kind of patients, they are left on medical management, and they would eventually require cardiac transplantation. So anybody who has heart failure with reduced ejection fraction, you have three options. Either you remodel this left ventricle, which can be done with the help of CRT or with the help of ACE inhibitors, beta blockers, or you restore this left ventricular function, which can be done by various methods of using revascularization techniques like PCI or bypass surgery, or it can be done by various LV reduction surgeries. Or you can replace this ventricle by either a transplant or by left ventricular device. So anybody who has not done these transplants and VADs would think that these are relatively easy and patient can go for them, but then it's not easy. And the best treatment for this patient is to restore this ventricle if it is possible. So we did breast and redistribution thallium scan on this patient, which revealed that only apical area is infarcted and rest everything is viable. So this patient is in intermex, as we call in our heart failure jargon, in intermex class status 3, because the patient is inotrope dependent and is having heart failure. Though the patient did not have angina, but that is common in these patients who have diabetes, that they may not have classical angina symptoms. So unfortunately, I don't have the angiography from the original center because it was done outside, but I do have the pictures from our center, which we did. And just ignore the other things, just concentrate on the angiography. You can see in the leftmost picture that it's a distal left main disease with ostial LAD involvement and circumflex disease, which is the critical stenosis in the proximal circumflex. And there's a reasonable size diagonal flowing on the but the LAD is very, very diffusely diseased distally, and there's a septal giving collateral to the PDA. We were not at that point sure which PDA is left PDA or right PDA, but then of course it was giving collateral, and then you can see that right coronary artery is also very diffusely diseased. So this is the type of patient who is simply written off that they are not a candidate for any revascularization, and they can be left on medical management, while these patients, they suffer a lot. So what is the option? So is it medical management option? Patient is admitted in the ICU. He requires inotropic support very frequently, intravenous diuretics. So he has a very high short-term mortality. And at 1 year, the mortality is going to be as high as 50% because the patient has had multiple hospitalizations. In any case, he would need LVSS device or transplant if you're not able to manage. And this is the old data in 1999 from Samuel's paper, which showed that the mortality goes exponentially high if the patient is on one or more inotropes as against those patients who do not require it. Of course, is then a bypass surgery an option? I don't blame my surgeons who rejected the patient because the patient had very high mortality and did not have any targets. You can see the LED that it hardly had any supply dystally, and the surgeon would say that, I can't see any vessel anywhere where I would put grafts, and these are all diffusely diseased distal vessels. So of course there'll be very high risk surgery, and they would not agree to that. Of course, angioplasty is an option. You can just open those proximal vessels and hope for the best. But these patients, they are very delicately balanced and may have very high morbidity and mortality. And we know from this Shock 2 trial, which was presented by Holger Thiele in 2012, that the IBP or the medical management does not change outcome in these patients who are in pre-shock or shock situation, who are requiring inotropic support. So what is the option? The option is the chip procedure, which we are all talking about, and protected PCI in that. So we had a discussion in our heart team, and after that, the patient was taken up for protected PCI. I would still say that while you are committed, you have decided that you will go for protected PCI, it is still wise to measure hemodynamics in the cath lab and take a step back and then decide whether the patient truly deserves a device or not. And in this case, the heart rate was 100. The systemic blood pressure was 96/70 with a very narrow pulse pressure. Pulmonary artery pressures were high, more than half of the systemic pressure, and the pulmonary artery saturation was very low. So we decided to institute Impella support, and we used Impella CP in this case. As is true for any large bore access, any chip procedure, the vascular access is most important, and you should pay very meticulous importance to that. Otherwise, you will buy more complications. So it is always nice to use a micropuncture set and then take a proper puncture with a micropuncture, and then see that you are in the middle of the head of the femur, and you have the puncture side is all right. And then if you're using this device and you may think that patient may not require it for a very long duration, then we always use 2 proglides to pre-close the groin. Of course, we should have familiarity with large bore access. Some of these patients may have very diseased femorals or may have too many catheters already going in. So you should have familiarity with alternate access, and Raj has shown us in a great way how to use axillary arteries for that. You should be familiar with access closer, and then you should be familiar with how to avoid and manage complications. So that's how Impella was put. I don't need to go into great detail for that. Of course, you put a pigtail in the ventricle, and then you pass 1 8 wire into the ventricle. And then on top of that, the Impella catheter goes in. And then you see that the Impella is nice and that marker, that little ring that you see should be at the level of the aortic valve. So it should not generate too many ectopics, and the trace, the power trace, and the console and the pressure trace should tell you that you are in the ventricle. The inlet port is in the ventricle, and the outlet port is in the aorta, so that the optimal position is monitored. After that, it was easy. We decided that the left is a very complicated system. There's a CTO of the circumflex, so we should treat the RCA with whatever it is worth. Of course, it was a very small vessel, and we did not realize that in first. So what we did, we put the guide catheter, and then of course the guide was not giving enough support, so we had to pass 1 wire into the conus branch, and then another wire into the distal RCA, and we stented the proximal artery. But we realized it's a small vessel and does not have much branches after that. However, it did fill some of the distal LED there, and we thought that will give some support to the left system when we are treating that complex vessel there. Then coming to the left system, we first thought that we should tackle this lesion in the proximal circumflex. So we passed a wire, it was a crossed 200 wire with the support of microcatheter, which crossed this lesion. And then we dilated with a 2 millimeter balloon. And then to our surprise, and a pleasant surprise, in fact, we saw that there's a large circumflex artery coming out of this area, and we had to treat this, fix this artery. So we did a bifurcation stenting to this. First, we put a stent into the main circumflex artery, and then did a tap into that, and then did a kissing balloon angioplasty to finish that. circumflex. And then we dealt the left main bifurcation, proximal LAD and proximal circumflex, in which we put one stent from circumflex to the left main, because we thought that circumflex is the main vessel and large vessel, while the LAD has a diffuse disease display and is also infarcted. So we put one stent overlapping with the distal circumflex stent into the left main. And then through that stent, we did a tap stent into the LAD. And then this is the final result that we achieved in this patient after the angioplasty of the left main as well as circumflex. We did OCT also. Unfortunately, I don't have those pictures, but then it was well deployed stent, and you can see that it's a beautiful result on the at least circumflex system, which is a viable system here. The LAD still there is some residual stenosis which did not go even after repeated OP and balloon dilatations, and the distal LAD remains diffusely diseased, and we know that it's infarcted territory, so we did not chase that after that. So in this case, while during the procedure on Impella, the hemodynamics improved, the aortic pressure soon came to 130 and pulmonary artery pressure dropped to 35. We see these frequently on in these patients who are on hemodynamic support, that they have better hemodynamics as soon as the device is switched on. The patient tolerated the procedure well, despite this was a left dominant system, and we occluded it for multiple times while we were doing the bifurcation. In fact, we treated 2 bifurcation lesions, one in the circumflex and the OM, and one in the left main. So it's a complex left main intervention. Total contrast volume was 350 ml, despite being very conscious about it. But despite that, the patient did not suffer any kidney injury, and the continued to have good urine output during the course of the hospitalization. We did not remove the Impella in the cath lab because this was a not only a protected PCI but also a cardiogenic shock situation where we wanted to make sure that the patient remains stable after the procedure. So we shifted the patient to CCU with the sheath in, and then after 4 hours monitoring, the patient continued to improve, and the hemodynamics remained better, and so we removed the Impella in CCU and then closed the groin there in the CCU. The patient was able to mobilize next day and was discharged 2 days later. So at 1 year follow-up, the ejection fraction has improved to 40%. He remains asymptomatic and is off diuretics now. So I would think that these kind of patients, if you have these support, then you are able to manage these patients better. Thank you.
Excellent. Thank you very, very much. That was a very interesting case, and in particular, a very nice demonstration of how you risk stratify people depending on the nature of their disease in the context of the rest of their clinical issues. And I think that's what we keep getting at here, right? Is picking the right therapy for the right patient every time. And for that, recognizing that we don't have all the answers now, particularly in different environments, whether it's India or the United States or the UK or other places in the world, but that an honest look at our own experiences, as Rustam mentioned, with studying case reports and studying our own experiences at these types of meetings, through which we're able to be able to define how things are likely to suss out in complex PCI practice. There was a question from the audience. Do we need to use hemodynamic support on every left main that we come across, or every multi-vessel PCI that we come across? Rustam, what are your thoughts?
Of course not. Left mains can be done easily most of the time without support, unless it is very calcified bifurcation distal left main, as the case that was just shown today with OPN. That particular case, Impella went off on the table. If I did this case, I would probably just did it through rotablation, where it's a case where you actually need to debulk a little bit, and then I would continue with Impella until next day because of possible complications with microcirculation. And as in the last case, it was mentioned, and there is plenty of evidence that renal dysfunction can be prevented in this age group, especially when they are old people. Now, how good it is to compare the old elderly patients that were presented early today, where we do these procedures with Impella to improve their quality of life, where no other option available, to this last case where it's a young man actually And by doing this procedure, he will live longer, he will have a better quality of life. And Dr. Rastogi could do this procedure comfortably, vessel by vessel, comparing to if there was no impeller, it would be very quick, probably just fix one vessel, come back again a few days later for another one. Impeller is a great device if it's used appropriately, and can save lives and protect us as physicians and achieve complete revascularization in most of the cases.
Yeah, I mean, I think your points are all very well taken, and that, you know, it keeps coming down to the same thing, right? Tailor your therapy to your patient. Don't use a device and tailor the device's output to, you know, what you're trying to achieve without really taking into account the patient. And Vishal, you had mentioned a few minutes ago some of the data out of IABP Shock 2 and how there was no real difference with medical therapy and IABP, suggesting that the IABP wasn't helpful. And I think that's it's important to recognize that we're talking about high-risk PCI here, right? So cardiogenic shock and high-risk PCI patients, those are apples and oranges, because they're fundamentally different patient groups once they've already come in declining. And if you look at data from, you know, I think it was JAMA about 10 years ago now from BSIS-1, where in the UK they looked at large cohorts of individuals who had upfront IABP versus who didn't, there wasn't a hard outcome difference between how those patients did until you looked much further out, you know, where the curve started to separate. But there was a reduction in procedural complications, right? There was reduced CPR, there was less VF, there was less hemodynamic instability while on the table. And so the devices that are put in up front, be they a balloon pump or a tandem heart or an Impella or what have you, are about providing the adequate amount of support that patients need. And so I don't think any one of those devices doesn't provide any support. It's just the key of deciding who's going to need in as much support as you can provide, right? The individual with low EF, MR, and severe calcific left main or multivessel disease with maybe a CTO in one vessel will probably need more support because of a higher likelihood of complications and more complex intervention than, say, your average individual with a low EF and one difficult to treat but very doable vessel.
Yes, Sanjog. So, you know, my patient was also a case of not just protected PCI, but also cardiogenic shock, because he was inotropic dependent. He was, so, you know, I was just trying to make that point. However, we all, as interventional cardiologists, whatever Holger Thiele may say, and then have had a long discussion with him, and because of that, probably Europe is not, Germany is at least not using IVP at all now. But we all have seen these patients being saved on IVP, and we've been using IVP for long in these kind of population. And at least I believe that IVP does have a role to play still in this population. So my point is that it's just a matter of how much support we give. IVP gives certain amount of augmentation. Impella 2.5 gives a little bit more. Impella CP takes to the next level. And then probably ECMO has much greater support, though it has its own issues. We'll not go into that. But the point is that not only we need to decide which patients are going to need these devices, but also at what level or at what hemodynamic level we should use. Whether, as of now, it's just a matter of hunch that we used Impella CP in this case. We could have just decided Impella, LP also, or 2.5 also, and we don't have a hard data to support that one device versus the other. So while we are thinking whether to use Impella or not, we should be able to judge whether the patient is okay on IBP or the patient is going to be okay on 2.5 or a CP.
Yeah, no, all valid points. I think that's the most difficult part of this, right? Is trying to dichotomize put in versus not put in, implant versus not implant, trying to dichotomize these challenging situations where there are so many different patient factors that lead to one particular decision being made. And that's why I think the important lesson is get as much useful data as you can upfront about your case, the hemodynamics, and all of the various patient factors to be able to help yourself define that balance between risks versus benefits. Doesn't matter what you're going to do, whether it's a simple PCI or an implant of a complex hemodynamic support device. So with that, I will thank all of my co-panel members and speakers for an excellent session, and close out the session on hemodynamic support and kick it back to you. Thanks very much for having us.
Thank you, Dr. Kalra.
Bye.
Thank you, everyone, for joining.
Bye, Raj.